All right, so let's see. All right, so we'll go ahead and get rolling here.
Okay.
Hopefully we'll get everything covered. It's kind of a lot of stuff to cram into an hour and a half.
Yeah, it is a lot of information.
Yeah. So daily operations in ambulatory care setting. So as again, just like in the other chapters, you've got your terminology to be aware of. The medical office environment, this is opening the healthcare facility, and they talk about it being an ambulatory care setting. It can be very similar to an office setting as well. So wherever you work, there's going to be limited, probably, number of employees that are given keys, or if it's like the punch lock, codes to get in. And the reason for that is because the less people that have that type of access, obviously the less can happen to charts, and it's easier to monitor who comes in, who comes out. The electronic ones or the card swipes, some places have those now. Those will actually timestamp when people come in, when people come out. So a few employees will be given keys, and if they have alarm systems, they will be privy to having the codes to deactivate the alarm systems. But the medical assistant is responsible for getting the office or your department ready for that day. The last chapter we talked about sometimes it's better to the night before allow yourself some time, depending on the way the schedules work, to get as much stuff ready for the next day as you can, so you're not worrying about it coming in the next morning. Answering services. With answering services, some you physically have to call and get the messages. Others will fax you the messages, so depending on how that works with whatever answering service you have, you want to allow time for that, because obviously if it's been a long holiday weekend and you've got to call in and they've got to physically give you each one of those messages, you could be on the phone for 15 minutes. Versus if they fax them to you, you can go through them, see what's important, and then take care of them as you have time. Prepping the charts, making sure what the provider needs is on there. Typically with the electronic health records, it's making sure that if the patient was in 2 weeks ago and had an MRI, for example, you want to make sure that MRI is in the chart so the provider has it to review with the patient. It's one thing if the provider goes in the room and they're there to go over lab results and the lab results aren't there, not only does it make the physician look silly, but it makes them a little mad too. Mm-hmm. Waiting room areas, make sure they're presentable for patients. Make sure the magazines aren't construed all over the place. Most places may have a TV in the waiting area. If you do, you can put it on something that's kind of low key. Some places will just put it like on a music station, just so that there's noise in the waiting room, so that it's less that they can hear, through the windows and so forth. You have to prepare the exam room, so turning on the lights, making sure you've got supplies in the room, that the tables are clean. You need your blood pressure cuffs, anything like that, all that is there. If your provider uses eScribe, so prescribing electronically, great, then they're going to be able to key in with passwords and do that. But if they're not e-scribing and they still use prescription pads, you want to make sure that the prescription pads are not kept in the room where the patient can have access to them. We had an incident years ago where they were in a drawer and the provider was running late, and by the time he got in there, he had realized, he went to open the drawer, realized there wasn't any in there. He knew there was because he had just been in that room right before. So he knew that patient had actually gotten in and taken them while he was waiting. So keep them in the medical assistant area or in the doctor's office, whatever it happens to be. Supply cabinets unlocked, except for if you have a narcotic one. Those should stay locked at all times until you have to go in. If you have equipment that needs to be like quality monitored, so like a lab machine, if you need to make sure it's all ready to go to run a test, if the doctor needs to have one, you have to make sure that that's all set to go. Worst case scenario is, he draws blood or he has somebody draw blood and then the machine's not working because it wasn't checked that morning.
Right.
On page 178, they show you an example of what a prescription pad is, which I'm sure you're well aware. So opening the healthcare facility and then closing the healthcare facility. So again, similar types of duties, making sure your records, documents for the next day, turning off computers, copiers, if the phones need to be switched to the answering service. Depending on the answering service you use, some you physically call and switch over, others it's automatic at a certain time. Cleaning the reception area, if you're a family practice and you have toys, those should be disinfected daily. A lot of offices will just use regular old Lysol spray. Again, magazines checked periodically, garbage removed, TV if you have one or stereo, make sure those are off. Make sure that all your patients have left the exam rooms. We had one patient once that was in a room, the doctor completely forgot and the doctor left. And thank goodness that the medical assistant went and checked the rooms. The doors were closed, but because there was somebody in there. Restock the rooms. So if it's a casting room, make sure that they've got enough of each of the size of rolls for casting, if that be the case. Patient-related documents put away, computers shut down, equipment or instruments that may have been used for procedures, make sure they're sterilized or packed and ready to be sterilized, depending on how long the machine takes to run. You may also be responsible for, if you're the last person out the door, shutting off the lights and activating the alarm again. Just some basic things. Daily and monthly duties, maybe, daily duties, cleaning the bathrooms, mopping kitchen floors, bathroom floors. Usually that's not going to be our jobs as medical assistants. You're usually going to have a cleaning company, or if you're in a hospital professional type building, usually they have cleaners that come in and do it. But it may not be uncommon to, if they only come in, I don't know why, but our cleaners only come in once a week to do a good thorough cleaning, and they come in every night just to empty the trash. So if there's something that we need before that good once a week cleaning, then that's something we have to figure out to do ourselves. So we would allow more time for that. Again, cleaning and organizing the reception area, the exam room, checking medications for expiration dates. If you get samples of meds, you want to make sure that your ones that are due to expire are closest to the front. You don't want to give out expired medications. Crash carts. Up on the top of this page is a picture of one. Most offices aren't going to have something that big, but they will have something available should they need, and we need to make sure that whatever we have on there for materials is current, nothing's expired, and everything's ready to go on it. Security in the healthcare facility. Again, stay alert for suspicious people. If you put a patient in the room and you're a little leery, keep the door open. You don't have to close the room when you go in to room a patient if that's part of what you're doing, taking their vitals or whatever. Keep yourself close to the door. Or if it's someone you just do not feel comfortable with, then bring somebody else in the room with you or notify the provider. There are instances where there are just going to be people searching for narcotics, or they're going to be mad if the doctor doesn't give them a prescription. And those are the people that we as staff should not have to deal with. So your providers need to step in at that point. You should have procedures in place for dealing with those suspicious people or potential robberies. And again, that would be in the policies and procedure manuals. Some places will lock employee entrance doors at all times, because if it's an employee entrance, only employees should have keys to get in that door. So hopefully that keeps people maybe out of the backside of the office. Most offices will have a check-in area, but the door that comes into that check-in area can remain locked, so there's no way, even if somebody's out in that waiting room, that they can come through unless they come through the glass window if it's unlocked or whatever. Again, alarms after hours. If the alarm is triggered, the alarm company notifies the police department. So at that point you would be covered. You would have people on the way. Equipment and supplies. It may be our responsibility to keep track of this, and it's pretty basic information. But with the equipment, we need to know how to operate it. If it's going to be something that the physician is using in the room, we want to make sure we are comfortable with operating it in case the physician doesn't know how. We also want to keep inventory of each piece of equipment in the medical practice. This is good because if the doctor is asking how many blood pressure cuffs, we can say this is how many we have. We can keep track if like one is out of commission or broken. Then we can look and say when we ordered another one, if it's come in, if it's not come in. Sometimes the practice manager may be this person that does equipment inventory, but I see a lot of offices now letting the medical assistants do it because they are more hands-on with the equipment than the practice manager. They're not the ones using it all the time. So again, keeping inventory, thermometers, glucose monitors, anything like that, computer hardware, calculators, copiers, those are large office equipments for tax purposes. They depreciate over 5 years. Office furniture, exam tables, those depreciate over 7 years. So sometimes that log will have the dates of when they're purchased, and then if they need to be replaced earlier than 5 or 7 years for tax purposes, we have the appropriate documentation to give the accountants for that purpose. That's why they're not written off all at once, because they want, hopefully they're going to last as long as they say they're going to. So you can do it via a spreadsheet. You can do both administrative and clinical equipment on one, or you can break it up. But it should have equipment name, manufacturer serial number, when it was purchased, the cost, probably not so much, because that's probably not something the practice is going to want everybody to know how much they paid for it. If you look on 180, just an example, small spreadsheet, laser printer, there's the serial number, where it is in the office, where we bought it from, and what, if any, warranty we have on it. Because that way, if we're calling to have, you know, we've got a line across the printer, we can tell them it's the one in the back office, the one up front, and our warranty is good till 2018. So we have all that vital information to give them. Equipment safety and maintenance. We should monitor equipment safety for proper functioning, meaning make sure to check the electrical cords for computers, routinely clean equipment that needs to be cleaned. Maybe that's keyboards, maybe that's scales if people are stepping on the scales. Maybe that's x-ray tables, exam tables, anything like that. If there is a operation manual with warranty information, make sure that that information is kept in a central location. If it's in the practice manager's office, that's locked when he's not there, and we need to be able to access that information. We need to be able to do that. So a central location is easier. The operation manual will have information on routine maintenance, cleaning, service schedules if it's something that needs to be serviced, and typically they will have a couple pages of troubleshooting. So if this is not turning on at all, try this, that type of thing. Copiers and printers need toner cartridges, so we can also make that part of the spreadsheet when we need to order the toner or the cartridges, because that's the worst thing, is to not have it there and then have yourself run out and not be able to copy until the next day, or not be able to receive faxes. Your logs for the maintenance, if you look on page 181, again, it's got the equipment name, serial number, manufacturer name, when it was purchased, again, the warranty information, who to contact for service, date and time maintenance, activities that were done, maintenance activities performed, and the signature of persons performing the maintenance. So again, this could even be for fire extinguishers, because those need to be checked every so often to make sure that they are still in working condition. And it's probably something that you could use your equipment inventory list, some of the information on that, and turn it into a maintenance log as well, seeing it's a lot of the same information. Service calls and warranties. So typically some of your equipment that is purchased for your office will have warranty. We need to know how long that warranty is good for and what it covers, so that if something breaks, we either know that we are getting a complete new one or that parts are covered. So before we go and say, look, we need to order a new, $5,000 table, this is broken, but the warranty will cover, whatever portion of it. And then they have a good idea cost-wise what they're looking at. Purchasing equipment. We are probably not the ones that are going to actually purchase the equipment, but as medical assistants and we use the equipment day in and day out, typically we're going to be asked what works best for us, especially if we're using it. With the exam tables, we may have an input on what type. Sometimes the doctors will come out and they'll say, we need a couple more blood pressure cuffs, but I don't like these ones. Can you do some research and see what you can find? So sometimes we're going to have to research, get that information, and then provide it to the person that is purchasing. The provider and supervisor may opt to lease a piece of equipment. I don't know nowadays, buying outright and leasing, I'm not really sure which one works out best. I know some offices actually lease their computers instead of buy them outright, just because that they need to update them so often that they figure it's much more efficient for them and cost efficient to do that. It may be, but so again, here with leasing equipment or technology, we may be able to help the provider identify new models or something that might work better than what we've already got. We can also let them know if the machine that we have, they may not know that our copier jams every time because they don't use it. So if they're saying we need to buy another copier, let's just get the same one, they don't know what kind of issues we've been having with it. So we may need to let them know that as well. Supplies, that can be the same type of thing. So your supplies are, I like to consider the supplies, we do it two ways in our office. We have the supplies for like the exam rooms, the injections, the needles, the casting, all that good stuff. And then we have the office supply stuff. We have two separate people that take care of that. One that monitors the rooms for the equipment for the doctors, and then somebody that monitors the office supply, the paper, the correction tape, toner, whatever it happens to be. So again, if that is us, we need to have a list. We need to take inventory of these supplies, have a process in place. So if somebody's going and they're opening the last box of paper, copy paper, when that box is opened, they let you know so that you can then in turn place that order, not when they're taking out the last package of paper. Again, keep a list, a record of each item in inventory. Can be manual, index cards, computerized, spreadsheet, but again, should have item details as far as the name, size, quantity, item number, the supplier's name, how much do we typically reorder. Sometimes the gauze is in packages of 5. If that's how we order it, then put that so that whoever is ordering knows not to separate and just order one thing and think they're getting 1 when they would indeed be getting 5. Reorder point, so again, that's with the ream of paper. If you're down to the opening the box, that's when you let somebody know. Again, the injectables, same type of thing. If the doctor is giving an injection, and I would say, there's 2 bottles in the room and 1 he's just finished using, that's when they need to let you know when they've tapped into that last bottle. So we have enough time. If it's on back order, we're going to run into issues. If it's something we can get within 1 or 2 days, we're going to be okay. But have a process in place. To make inventory management work well, a quality control system should be in place. Monitoring usage, making sure the inventory is checked. Some people use codes to track inventory, billing supplies, whatever is going to work best. But again, typically there will be one that takes care of like the front office supplies and one that will handle the back. Again, several manual systems for identifying when the supplies need to be ordered on 184. Again, you could have a notebook and they write in there what needs to be ordered. Slips with the name of the products or little index cards that they may put in a box for you. There's a 2-bin system, having a main bin for each item in inventory and then a backup bin for each. So when the main bin is emptied and they go to the backup bin, that's when they know they have to tell somebody it needs to be ordered. So again, the medical assistant responsible for ordering does a hand count of the items in stock, find out what needs to be reordered, and go from there. Again, the taking inventory is pretty straightforward. Again, it may not need to be done weekly. Maybe it's every other week. Maybe it's once a month. It depends on how often your docs are in the office, how much those supplies are used. Our doctor, if they're seeing 60 patients, all 3 of them, if they're seeing 60 to 70 patients a day, and they could be giving 10 injections a day, we're probably going to have to check supplies once a week just to make sure we've got enough in place. When you do a count, use an inventory list. That will help. Also make sure that if you're doing inventory, which is kind of common sense, work in a systematic manner. So you're starting from the top, start from the top to the bottom. Don't start here and then go down here because this item is kind of related to that one. Do it in a systematic manner. Price consideration when ordering supplies. This can come into play with quantities. 1 to 5 might be $5, but if you order 5 to 10, you save $2. It's going to depend how frequent you are using those. So if you're keeping an inventory and you can see in 1 week you used 5, then it may be beneficial to up that order the next time and get the 10 to save money, especially if it's an item that's not going to expire, like the gauze, if you're or Band-Aids, if you're using injectables or like the Neosporin or ointment, something that can expire, those you want to make sure you're not ordering too much of and then ending up having to throw it away. Even the casting material that comes in a thing, once you wet it, that actually expires. So it's not good to keep too much of that on hand if you're not going to be doing a lot of casting, because then you've just thrown all that money out the window as well. You can join purchasing groups. I don't know of any purchasing group organizations for the medical supplies. There is a place in Portland that you can pay a fee and you can go in and get office supply stuff, whatever you want, however much you want, but you pay a fee every year to be able to do that. Sometimes that may save, depending on, how much you're going through for office supplies. It may pay for that yearly fee. And when you order supplies, keep a list of vendors. We try to buy all of our medical supplies for our exam rooms from the same vendor. We try to buy all of our office supplies from the same vendor. But if something is really much less expensive through another vendor, then just make sure you keep that list, so if somebody has to order it while you're out, they know those vendors that you are using. Most of the suppliers will have you create accounts. You can order right online typically, or make a phone call and order. So it's pretty easy to do that. The narcotics, if you're ordering narcotics, those require special tracking and authorization before they are purchased. So that may or may not be something that we are given the authority to do. It may have to come from the provider himself. Sometimes you'll have purchase order numbers. Some of the supply places will send you an invoice. You have 30 days to pay. Others will want payment up front with a credit card. And some will allow you to use purchase orders. So you'll want to get a feel for what those vendors use, and then that will enable you to make a better decision as well. Again, the payments, credit cards, check, money order, line of credit, the invoices, typically 30 to 60 days to pay depending on the item. Make sure when these orders are placed, if you are faxing or mailing, make sure you keep an order of the, keep a copy of the order, so that when it comes in, yes, you're going to have your packing slip, but you can also compare it to your order in case something you ordered isn't on that packing list at all. You have proof that it was ordered. Once you receive the order, it can come FedEx, UPS, sometimes regular postal service, but the delivery should be checked as soon as possible in case there are items in there that may need to be refrigerated. So it gets opened, your packing list is there, check and make sure everything is there, what's on back order. If everything is there, then it's fine to take that packing slip and give it to whoever handles the accounts and pays those bills, because we know everything has come in. If something has been back ordered, then we hold on to that slip until that item finally comes in. That way we're able to track what we've ordered and we don't double order it again because we don't have any in the rooms. Packing slip be attached to the order and given to accounts payables. There are storage guidelines for vaccines. So if you are a primary care office, pediatric office, and you're supplying vaccines, when they are ordered, you want to make sure if they need to be refrigerated or what temperature they need to be kept at, and make sure that it is appropriate. Again, make sure to put away the items as soon as possible. Get rid of those boxes. Always put your new stock in the back, so your older stock will come forward. That way you're using the older item first. Again, any items with expiration dates, make sure those go in front so that they are used first. So again, new stock, put it behind. On page 188, handling the mail. So a lot of times medical assistants are responsible for going either down to the box at the hospital and picking up the mail, or if the mail's delivered, sorting the mail. So if that's your responsibility, we want to make sure that you know what goes to whom in the office. Also, we want to have an idea of the different types of mailing that's available. I don't actually know how many offices still have postal meters. Some of them do it online. Some of them will still have a meter in the office that you can weigh stuff and then put the appropriate postage on. But you want to be aware, if you're sending a postcard, the thickness, the length, letters, what qualifies as a large envelope, and then about the different types of mailing. If the doctor comes out and he's got a disc for an x-ray that needs to get down to Boston for somebody, and he needs it there right away, and he asks what's available for mailing, we should be able to say, well, there's a priority mail, 2 to 3 days, typically runs, this amount, or we can overnight it, but it's obviously going to cost more. Just having a little bit of that information. Priority mail, 7-day-a-week delivery service. Most of the priority is 1 to 3 day delivery. First class provides delivery in 3 days or less. Envelopes weighing up to 13 ounces can be mailed first class. Standard postal ground service for oversized, less urgent, up to 70 pounds, but it needs to measure 130 inches in combined girth and length. Media mail, so there's a special rate for CDs for that media to be mailed. So we don't want to mail at regular postage if there's a media rate, because that media rate is obviously different. Insurance and additional services. So as you're aware, I'm sure, there's typical regular old mail, but then you can also insure it. You can send things registered mail, to which you get a receipt provided. Certified mail is an option for first class and priority. If you look on this 189, the second paragraph down towards the bottom, if your office terminates a patient, Maine does require that a termination letter be sent, certified mail, return receipt requested. By doing that, I believe the guideline says you have to give that patient 30 days to find a new provider. In that 30-day window, you will provide care for them on an emergency type basis if needed. But you have to send it certified receipt so that you have proof that they got that termination letter. Otherwise, they could come at you with legal action and say you were refusing to take care of them. But by doing this, you've covered your basis. And down at the bottom is what that certified return receipt looks like. On page 190, there's private delivery services. So the United States Postal Service does a portion of the mail in the United States. But again, there's UPS, there's FedEx, there's DHL. All of those that are private delivery services. The drivers may be bonded, depending on what they are delivering, but they can do pickup and delivery of medical specimens, so going from a lab to a lab or an office to a lab, transporting medical records from one location to another. So, if it was a large chart and there was no way for it to get there other than this type, and it had to be where the patient was having emergency surgery, we can use this type of thing as well. If you look up at table 11.3, these are the optional services by the Postal Service. So they offer tracking, certificate of mail, adult signature, return receipt, collect on delivery, hold for pickup. So there's a lot of different things. So just knowing what's available out there in case they ask. Again, back to the incoming mail. If incoming mail is marked personal, we don't touch it. We make sure whoever's name is on it gets that mail. Anything else, usually they will give us the okay to sort. Now, whether that means you sort by looking at the envelope and determining what it is, which 9 times out of 10, you can tell if it's like an explanation of benefits or something like that, or physically opening the mail and putting it on the person's desk that is responsible for that. Continuing medical education, professional journals, those typically go to the providers directly. The provider may not want us to touch the mail, and they may just say when the mail comes in, set it on my desk. And they actually will go through and sort the mail themselves. I would stress at that point that if they're not going to be in a situation where they can do that daily, that it should be assigned to somebody else, because sometimes stuff should not sit. So again, but that's just making a recommendation. Mail related to patients, labs, x-ray tests, open, dated. 9 times out of 10, offices have a stamp, so you can just stamp the date that you received it. Some offices, if they're scanning into electronic health record, they may want to just put the patient electronic health record number on that piece of paper with the date that it was received, so that when it's scanned, that information is already on there. Magazines for the reception area, supply shipments, anything like that that we can take care of, we can handle. We should have a procedure for handling mail that's not addressed to somebody. So if it's just addressed to the name of the business, have a process in place. So who gets that mail? The practice manager, the supervisor, the provider, whatever it happens to be. And also when that provider, if they're the ones that want to take care of the mail, there needs to be a different process for when they're on vacation, because again, we don't want it laying around. Occupational Safety and Health Act, or OSHA, talks about body mechanics. So their big thing with OSHA is injuries, and back injuries are one of the most common injuries in the medical practices and other places. But repetitive activity over time, lifting, improper lifting, reaching, twisting, bending, bad body mechanics, poor footing can even result in back injuries. So we need to protect ourselves from bodily harm when we lift, reach, and carry heavy boxes and equipment. And also if we're dealing with patients and we need to possibly help that patient up to the exam table or move them from the wheelchair, whatever it happens to be. If you look on 192, it shows you the correct way to lift a box and an incorrect way. So you should bend at the knees when you are lifting, not just bend your front body. And sometimes you have to stop and think about it, because sometimes it's just reaction to bend down like that and not bend your knees. But depending on the weight of the box, it could clearly do some damage. And then also whether you keep the box close to you or try to lift it out further away can also make a difference. So in closing, proper body mechanics. So again, back injuries, top of the list. If you are going to be doing a lot of lifting or anything with the equipment that requires twisting or turning, make sure that you know what the proper lifting or mechanics are. The medical assistant has to help protect the medical practice from lawsuits. So again, medical assistant to file a copy of any document sent to a patient in the chart, whether it's paper chart or electronic chart, should always keep a copy of anything that is generated with regards to a patient. When certified mail is being sent, make sure everything is attached in that patient's medical record, especially when it comes back signed or refused, so that we have a copy of that. Without that evidence, if a lawsuit happens, we don't have a leg to stand on. Any questions with regards to opening up, closing the office, inventory?
Not really. It's
Nope.
pretty self-explanatory.
Yeah, it is. Pretty straightforward.
Yeah.
And, for as much as it is straightforward, you do have to make sure the proper protocols are in place. And when you sit for the exam, some of the stuff that is straightforward, I found myself almost second guessing myself on it because it's like, is it really that easy?
Yeah.
But as long as you know those rules and regulations, I think when I sat, one of the questions was, if a patient is discharged from your practice, what is the process or something like that? One said do nothing. One said notify primary care. One said send certified letter. So, it's that simple, but sometimes you find yourself second guessing.
Yeah.
So, all right, so now we are going to move on to the health record, which is chapter 12. And again, we've got the terms. We will go over the two types of patient records, meaning paper and electronic, why accurate health records are important, talk about subjective and objective information, who owns the health record, the difference between an electronic medical record and an electronic health record, and following healthcare legislation with regards to electronic health records. And again, a lot of this is also kind of common sense. Health records, two formats, electronic and paper. A lot of facilities have switched to electronic health records for a variety of reasons. Some still remain paper. If they have switched to electronic health record, obviously depending on how long the provider has been in practice, you have to set a standard for how much of that patient's record are you going to scan into the new electronic health record. So do you just start from, let's say you start December 1st with electronic health records. Do you just scan the patient's previous visit? Do you go back a year? Do you go back a month? Some offices would go back 3 to 5 years. So let's say we start, January 1st, 2018. So some offices said that they were going to go back and scan anything for that patient back to January 1st of 2013. That's great because then they're going to have access to probably the majority of what they need. The problem with that was that scanning is not as cut and dry as it seems, and it requires pretty much an individual body just to do it on its own. Our system, we can't have two people scanning and sorting at the same time. So it has to be done by one person. So our process was a little different. We decided to do just the previous visit so that they had it, and then as the doctor requested, or if they were going to be scheduled for surgery, then we would pull that chart and do the entire chart at that time. We didn't do everybody. We did just patients as they came into the office, because we see people for broken bones and they may see us once and never come back again. So there wasn't any point of putting somebody's chart in there from 2 years ago if we haven't seen them yet. If they come in tomorrow, then we'll pull that chart and scan it in. Everybody's got a different process. Two major types of chart, again, the paper and the electronic health record. Obviously with a paper chart, only one person at a time can look at the paper chart, so that's a disadvantage. The electronic health record, much more efficient. Multiple users can access at the same time. Fewer errors because of handwritten notes. They don't need to be interpreted. You don't have to guess what the provider wrote because it's typed and it's in the electronic health record. Health records are kept for 5 basic reasons. Obviously, it's for care for the patient, but we want to make sure that everything is in order. So first, the health record helps a provider, again, with the best possible care for the patient. We need to know where things go in the chart when they come in. And this would be whether it's paper or electronic. Everything should have a specific designation or a folder. This will allow the physician to support the diagnosis for the patient. They can prescribe, form an opinion about the patient's recovery. Second, the health record provides critical information for others. So a healthcare professional can provide continuity of care. So if Dr. A is out of the office, Dr. B is able to look at that patient's chart and continue right with the same care that the provider was getting from the doctor that's out of the office. Third, health records are kept as legal protection. So an accurate record is a foundation for a legal defense. So that was one of the reasons for legibility, because if it's not legible, then it wasn't done, and that would not count at all for any legal case. If it's not documented, it did not happen. Fourth, health records provide statistical information helpful to researchers. So medications, reactions to medications, they can do research on, the state of Maine will run counties and will run cancer diagnosis codes by county. So they can see which county has the greatest population of people with prostate cancer or lung cancer. And they do research to see if possibly that lung cancer is tied into the mills that they work in or whatever it happens to be. And then we have fifth, health records vital for financial reimbursement, because we need to have it documented in order for us to be able to bill and get reimbursed. So what is in your patient's health record? It should contain both subjective information, which is provided by the patient, as well as objective, which is obtained by the physician or staff as they assess and examine the patient. So your subjective information, personal demographics, this is where the visit begins with the routine personal data. They supply it on their first visit. Typically, they complete a patient questionnaire. If you look on page 198, this is a nice, I think, registration form. It's got the patient's name, address, social security, today, the date that they fill it out, business, spouse information, responsible party. So if the patient is a minor, the parents obviously would be responsible. Insurance information. Do you have additional insurance? So if they have more than one insurance. And then down at the very bottom, I authorize release of any information concerning my child, health care, advice and treatment provided for the purpose of evaluating and administering claims and insurance benefits. And the patient signs and dates that. So when we submit the claims on those lines, I believe it's 12 and 13, where it goes signature on file, that's where this is coming from. So as long as the person who is liable for the bill is signing here and we have that little clause, that covers us on submitting claims and having the insurance companies send the payments to us as long as we are participating. But again, a variety of information, source of referral, so who's sending them to us. We then have past family, social, and personal history. Typically, this is, again, via done a questionnaire. And if you look on page 199, this particular one is a 3-pager. Talks about past history, social history, any medical problems, general health habits, allergies, medications. This typical past history form is going to depend on, is it the initial time that the patient's seeing the provider? Usually, if it's the first time that they've seen the provider, this is going to be a 2 or 3 page form. If it's a once a week, the patient's coming in for, checks, then obviously this level form would not need to be used. We could use an abbreviated form. But depending on the information that's needed, ours in the orthopedic office is 6 pages for an initial visit that we have them fill out. And then that is the basis, so we don't need to get that every time they come back. But sometimes if the patients can't fill them out, that's where we come in. We're going to put them in an exam room. We're going to go over this information with them. You can run into this with patients that can't write, patients that are blind. If they're disabled in some sort and they don't come in with anybody, they're going to need to have this information because the doctor can't see them without it. The past health history, this is previous illness, injuries, dates they occurred. That always helps the provider. Patient's family history, so various members of the patient's family, maybe cause of death. They're most interested in immediate family. So parents, grandparents, siblings, and children. It used to be that family history would be your aunts and your uncles and all of that. And now they have limited it to immediate family only. Patient's social history, so their lifestyle, alcohol, how much, nicotine, how much, what type, drug use, living situation, exercise, nutrition. On page 200, these are a couple of different stickers. We'll talk about the charts in a bit, but if a patient has an allergy and we're using a paper chart, we need to have that allergy sticker on the chart. There's no other way to flag it so that everybody knows that there's an allergy. Also, if there's a power of attorney or a living will, these stickers go on the charts. The copay sticker is great if your front office staff has the chart when the patient checks in, because then they can see the sticker. But again, that sticker needs to be updated. So if it's not updated with the correct information, it's going to not serve a purpose anyways. Our software that we use, actually, we can put the copay in there. So when the patient checks in, the first screen that pops up is the screen that tells the front staff what they owe for a copay. We talked about the history, social history, also the chief complaint. So the chief complaint is in the patient's own words, and it's why they are there or what are their symptoms, nature, location, frequency, duration of pain, how long, maybe what they've tried for treatments, have they had similar things come up in the past, other medical treatment for the same condition. The chief complaint from an audit perspective cannot be patient here for follow-up. It has to be patient here for follow-up for back pain. But if it just says patient here for follow-up, if we were to get audited, that is going to be considered a non-billable visit. Even though they've done the exam, they have met all the criteria, the chief complaint is not specific enough, and some of the auditors will not count that at all, which means they're going to make a suggestion to the insurance company that they take back money on that visit. And you can bet that once they ask the insurance company to take back money on one visit, we're going to be asked by that insurance company for several patient records because they will be looking for the same thing. And if they find it once, great. But if they find it more, they're going to take all that back. When we are getting the patient's chief complaint, if we're talking about a pain scale, so let's say we have to ask the patient on a scale of 1 to 10, what's your pain scale? That pain scale should be something that's in your policy and procedure manual, so that if they're saying the pain's a 6, what is that level 6, so that everybody across the board understands that same pain scale. The objective findings, so this is what the doctor observes and measures. So this can be vital signs, and this can be from the medical assistant as well, because usually we are the ones doing the vital signs. So patient's temperature, pulse, respiration, blood pressure, sometimes pulse oximetry, height, and weight. Those are all documented in the patient health record. Provider does use them in their assessment. Findings and lab for lab and x-ray reports. After the provider has examined the patient, the physical findings documented, results of test documented. If they're on separate pieces of paper, they will then be attached to the paper chart or scanned into the electronic health record. And then based on everything that the provider has seen with regards to their exam with the patient, as well as the patient's subjective information in their own words, they are going to come up with a diagnosis. Sometimes, if it's a questionable diagnosis, you may hear it referred to as a provisional diagnosis. In the world of coding, there is no such thing as question of. So we either code a confirmed diagnosis, such as appendicitis, or if they're trying to figure out if the patient has appendicitis and they don't know for sure, we would code the symptoms. But again, the doctor is going to come up with a diagnosis. Then they're going to come up with treatment plan and progress notes. So instructions to the patient for follow-up treatment, if surgery is scheduled, going over surgery, having them sign a consent form, anything like that. On each subsequent visit, when we have a paper record, the date needs to be entered on the record, information about the condition, results of treatment, based on the provider's observation, must be added to the health record, and notations, medications, anything like that, the physician needs to update in the chart. So the first time they're there, it's probably going to be a quite lengthy note that your provider is putting in there. when they're coming in for a subsequent visit, they're saying that that follow-up progress note should have information of what they've tried, what's worked, how everything came out, lab results, anything like that. When the treatment is terminated or the treatment is resolved, typically it would be what they would like seen is the date and say, wound completely healed, problem resolved. That's saying that the patient no longer needs to come back. A lot of offices will say, patient to return, PRN as needed for follow-up. That's an okay way to do it too. The medical assistant's role, responsible for documenting the patient's history. Care must be taken to ensure that the patient's answers are not heard by others. So again, if we've got that big long form, we don't want to be asking the patient these questions out in the waiting room. So we want to pull them into an exam room or a separate room and get the answers. If we have an electronic health record and you were, having the patient fill it out on paper and then we were going to key it in to the electronic health record, if we're getting the information ourselves because they can't fill it out anyways, if it's easier to put it right in the electronic health record than to fill out the paper at all, that's fine as well. It just needs to be documented, paper not filled out due to, entered directly into EHR. And then we have a documentation when the doctor asks, why wasn't the paper filled out? Covering our behinds, so to speak. If new patients have to complete the lengthy questionnaire, typically, if they're scheduled far enough ahead, send them the paperwork ahead of time, ask them to bring it back in, or have them come in a little bit early prior to their appointment so we then have time to review that and enter it into the computer. Some offices provide a patient portal with their electronic health record. So they can send you a link. You can go in, fill out that form, and then it gets sent back into the portal. The medical assistant may document the chief complaint, but the provider will question the patient in more detail. So all we can do as a medical assistant is write down what the patient told us word for their chief complaint. Other than that, we can't document anything else. If there are material that gets entered into the chart or stuff that is dictated, the best way to know that the physician has looked at it is by having them either initial it or sign it. And either way, it should be both dated and initialed and or signed. Ownership of the health record. This is a little bit touchy as far as patients are concerned, because patients think that their health record belongs to them. However, the owner of the health record is the provider or medical facility, often called the maker. They are the ones that initiated and developed the record. The patient has the right to access that information, but they do not own the record or documents in that record. So, we need to be a little bit careful when the patient says, that's my record. Yes, it is, but we own it. So they will also tell you in here that if a patient is removing themselves from your practice and they say, I want my actual chart, I'm taking my chart with me, that chart belongs to the practice. You can make a copy and they can take a copy with them, but you cannot release the entire chart, period. Copies are fine. Actual paper health record, if offices are still paper, cannot be removed from the office or should not be removed from the office. It should be kept in the office. If the doctor is doing a procedure at the hospital and he wants some of that chart, he should be making a copy of maybe last year's op note to take with him. but the chart should not be leaving the office due to privacy practices. If it is paper, obviously written health records must be legible. Each record needs to be written as if the provider and staff were to be involved in a lawsuit. That way, there's never any question. Everything is always neat and legible, which is really hard to do with a lot of providers. With electronic health records, that eliminates the issue of legibility, but it is just as important to make sure that all patient care is documented in the electronic health record. If it is not documented, then it wasn't done, and it can open them to lawsuits as well. Some of the technological terms in health information, again, the EMR and EHR, they're acronyms, and we have the Office of the National Coordinator for Health Information Technology, or ONC. They are the ones that develop the definitions for those EMR and EHR. So your EHR, electronic health record, is an electronic record of health-related information about a patient conforming to nationally recognized interoperability standards and can be created, managed, and consulted by authorized clinician and staff from more than one facility. The electronic medical record, electronic record of health-related information about an individual, again, created, gathered, managed, and consulted by clinicians and staff within a single organization. So we're a private practice. We have an electronic medical record. The hospitals typically have the electronic health record because it can be accessed by more than just a single practice. Your electronic medical record is an electronic version of a paper chart. So the advantages of having an electronic medical record, again, can be assessed from more than one healthcare organization. Continuity of patient care, much more easily established. What's nice about the EHR, too, is that if your primary care is linked to the hospital, if you're admitted at the hospital can access your primary care's records so that they know what's been going on. It's not just the hospital records in case you've never been there before. So that's about the continuity of care. They have access to get that information. There is something called a PHR, or personal health record, and this is an electronic record of health-related information about an individual. Again, it meets the nationally recognized standards. It can be drawn from multiple sources, but that is managed, shared, and controlled only by the patient. So this is somebody who is gathering all their information and they're managing their own personal health record, which some people may do if they travel or if they're winter birds like down in Florida. Those people, they may have their personal health record that they maintain and bring to Florida with them, because obviously Florida is not going to have access to our electronic health records or medical records up here. Another way for patients to access their health information is through a patient portal. So patient portal gives them the accessibility to look at their medical record. They can go in and see their visits that they've had with the doctor. They can only access their visits. They can't access anybody else's. It's just their patient portal. But they would be able to see anything that we've scanned in that patient's chart. So their labs or their x-rays or their operative note. Some people that are very tech savvy like the patient portal, and they can go in and they can just review to make sure that there were no errors made in documentation, for example. And other people, they don't want to worry about going on the patient portal to check anything. So it depends on the individual patient. HIPAA uses the term protected health information, which is any information about the health status, provision of health care, or payment for health care that can be linked to the individual patient. And HIPAA requires that all the PHI be protected. So that is the electronic health record, the EMR, the personal health record, and patient portals as well. In 2009, there was the American Recovery and Reinvestment Act. This was a stimulus package. It was passed, signed into law by Obama in 2000, and the technology aspects of the bill provided more than $31 billion for health care for the EHR investment. So that was really quite a big thing, and this was when a lot of offices decided that they would move in to electronic health record in 2009. The health information technology, meaningful use. So there was an act that provided financial incentives for meaningful use if you could prove that you were using electronic health record in appropriate manner, so to speak. So you had to certify that you were using electronic health record in a meaningful manner, such as e-prescribing. You had to use it for electronic exchange of health information, and you used it to submit reports, procedure, and diagnosis or other measures. So when this was implemented, you can see that there were 3 stages on page 203. Stage 1 was 2011 and 12. That was the electronic data. Stage 2 in 2014 was advanced clinical processes. And stage 3 was expected to be implemented in 2016, which is improved outcomes. So what happened with this is if the doctors showed the effort, got the electronic health record, showed meaningful use, and did certain things, then they were given money to help cut the cost of the electronic health record. Because in a minute I'll give you a rough idea of how much it costs to start up the electronic health record. So some providers felt that this act was good to get going because it possibly meant that if they could do these things, they may get some of that expense covered for them. If you look at the top of 203, this is just back to, again, the HIPAA, so the protected health information and stuff, just to give you an idea. If you violate that, so you say you didn't know, the violation can be $100,000 to $50,000. They expected over the course of a year to be able to collect $1.5 million in these did not know incidents. Reasonable cause, $1,000 to $50,000. Willful neglect, meaning you corrected it, so you found your error, you corrected it, you're not going to do it again, $10,000 to $50,000. Or willful neglect not corrected, $50,000 period. So those are just some standard costs for HIPAA violations, just to give you an idea. So again, we talked about advantages and disadvantages of the electronic health record, but the electronic health record does have several advantages over the paper. Again, it can reduce medical errors by keeping prescriptions, allergies, and other information organized. It can reduce costs of duplicating certain procedures. So if in the electronic health record, if a certain test was ordered and received back, that test is going to be in there. So chances of duplicating it are pretty slim. Whereas if you have a paper chart and you're looking through the paper chart and you don't see that complete blood count on Mary, then you're going to order it again, and maybe it just is sitting in the folder waiting to be filed. There's no way to really tell other than calling the lab if that patient had that. Again, another advantage with the EHR is legibility over handwritten, and more than one person can access the electronic health record as well. On 204, obviously with electronic health record, less storage space. I don't know about you, but years ago when we had paper charts, we had walls and walls and walls of paper charts. It's like you would run out of room, so you'd always have to take, a year out and put it in storage because you needed to make room for the next year. So this eliminates the need to purge inactive files. Files may be duplicated regularly and placed off-site as a backup. So in case, there was a possibility of loss of power or something like that, you have the capability with the EHR to still produce it in paper form and send that chart to storage and still have that. Information assessed in a variety of locations. Again, more than one person can access it. Patient information available quickly in an emergency, even if they may not be in their hometown, they might be on vacation. Providers can access it via tablet or phone sometimes, depending on the electronic health record. With the EHR, providers found that they could see more patients in a day with the electronic health record than they could via paper. However, the EHR had disadvantages. The lack of capital was the biggest one. Providers had a fear of learning a new system. Changing over to medical records, patients were worried that their private health information was going to be accessed by unauthorized people versus just a paper chart. Well, what they didn't realize was, what if that physician took that paper chart to the hospital for that procedure? Other people had access to it there. So electronic health record is much better. The startup cost for conversion, here we go, for a 5-provider practice, approximately $162,000, with $85,500 going towards maintenance during the first year. They also said that implementation teams, so typically anytime you go with a new practice management system or electronic health record, you have your key users or implementers, and they said that with these key people, they would train 611 hours. And then your front office staff, your MAs, they would end up using about 134 hours of training. So it's more or less train the trainers. So we would do the 611 hours of the training, and then we would condense that into just the training that is needed for those particular positions. But that big startup cost was, a little scary for some of the providers, and they didn't want to do it. But that act said, if you can do e-prescribe and this, we will give you a certain amount of money towards the cost. And I don't remember what the amounts were, but you had to meet deadlines by date. And as long as you did that, at the end of that period, you would get that amount of money back. I want to say it almost cut that in half for some of the practices. So if you're looking at cutting it in half, that's a good savings to the providers to, go ahead and push for that electronic health record. Space for the new equipment for the EHR can be an issue, although you need less space, but you still need your big mainframe for the computers. And where do you store the backups and all that. So that was another disadvantage. And then security and confidentiality. That was a big concern for healthcare providers as well as the patients. So ensuring them with the Privacy and Policy Act, how we were going to maintain those safeguards, who would have access to that information, and everything like that. Capabilities of the electronic health record. They can do a multitude of tasks, which saves time in the office. Specialty software, so patient data can be captured and processed in a system that is specialty specific, like we're orthopedic. So our electronic health record is specific to orthopedics. So our terminology that is pre-populated in there is geared towards our specialty. So that's a specialty software. Appointment scheduler. So this can have a scheduler which allows the staff to track, schedule appointments, recurring time blocks, merge appointments, so that lengthy procedures aren't scheduled in short appointment blocks. Some practices actually allow patients access to the scheduling portion so that they can schedule their own appointments. I don't know that I would want that, only because our schedule is so hard to figure out as it is, that if a patient put themselves in the wrong slot, it could really cause a problem if nobody picked up on it. On page 206, this is that SIM chart. So this is the electronic or a version of an electronic health record, but you can see you can search by patient on the left-hand side. You can pick a specific date when you're booking an appointment, and then you've got the time slots, and this one goes, you can change it by day, week, or month. And you've got searches up at the top, so you can look strictly at the calendar, patient demographics, you can find patients, and then it tells you on the left-hand side, the patient visits would be in blue. If we're blocking a time so that nothing gets put in it, it would be pink. And then your green might be, in this case, if your doctor is doing hospital rounds, or maybe it would be set up for a lunch or meetings or something like that. These practice management systems, EHRs, can also have appointment reminders and confirmations. It used to be that we have to send out handwritten reminders in the mail for like all our new patients. Now the electronic health records and the practice management systems, if you want them to, will do reminder calls for you. And it gives the patient an option, hit 1 to confirm, hit 2 to reschedule. So then if they hit 2 to reschedule, the next morning we have a message that we know that patient's going to reschedule, so we can put somebody else in that slot versus waiting for them to not show up at 3 o'clock. Prescription writer, so it can do e-prescribing, which can be sent automatically to the pharmacy or filled out and printed out for the patient. Some of the prescription writers have a patient allergy function, so it will block certain medications. If the doctor prescribes a certain medication that the patient might be allergic to, it will pop up and say, this cannot be given to patient allergy, or what have you. And then we have the medical billing system. So the EHR can also manage all the practices, billing, and accounting systems. So it interfaces with clearinghouse for claim submission and tracking claims. Reports can be generated to find out the status of claims, when claims have been paid, and so forth. And then we have charge capture. So this is storing a list of the CPT codes, the valuation and management codes. It can alert the user when a certain charge doesn't match a diagnosis code. The software can alert and help prevent errors leading to denials of claims. So this is really nice. It kind of like scrubs the claim before it goes out the door. Ours will tell us if we don't use enough digits on the diagnosis code. It will say diagnosis code not specific enough. If we use a diagnosis code that, let's say for a trigger point injection. A trigger point injection has a local coverage determination, which means it will only have certain diagnosis codes that it will pay with. Well, if we put a different code in there, ours will stop us and say, this has a local coverage, this is not a covered diagnosis code. So it stops us so that we can go to the provider and say, this is not going to be covered if you use this diagnosis code. Was the patient having something else? Can we support something else to use? And 9 times out of 10, it's just that they forgot to put the correct diagnosis code or that additional diagnosis code on there. So we're able to fix it, get it out the door, versus letting it go, having it denied, and come back to us. It will verify eligibility. So as long as the insurance does electronic eligibility checks, when your patient checks in, you hit the electronic eligibility check and it will tell you right then if that patient is eligible for that insurance. If it comes up not eligible and they're giving you that Blue Cross card, they're not covered, so we treat them as a self-pay that day. If it says not eligible, they're not eligible. They can call the insurance company and try to get it figured out, but that tells us we need to know, we have to have that money up front. Otherwise, they could be just giving us a card to get in the door and never have any intention of paying for that visit. Referral management, so again, it can manage those referrals coming from other providers. It can transport those records back and forth to the referring providers. So if a patient is referred by Dr. Smith to us for a consult, we can send that report once it's done right back to them. And then they have their results back. And laboratory order integration. This allows the user to integrate or interact with outside labs to get results and to be able to put it in the patient's chart as well as order lab test. Let's see. See, I knew we wouldn't make it all the way through that chapter because it was too big. So what we'll do is let's leave off on nonverbal communication with the patient on 207, and we will pick up there and then go into the pharmacology chapter next week because that's a good place to leave off. Any questions on what we went over this week?
No, I'm okay.
Pretty straightforward, huh?
Yeah.
All right. So, we will do that. All right. And if you guys don't mind, I'm just going to real quick zip to the ladies' room, and then I'll come back and we'll get started on Chapter 8. All right. How are you tonight, Kim?
I'm good. How are you, Karen?
Oh, good. Not too bad.
I'm so glad that I'm finally able to not just hear you, but see you as well.
I know. I
And I
know. For a
didn't
while there,
realize-
they were having quite the issue. This machine, somebody had broken off the thing in the back, so we had to go to the high school, and it was a nightmare.
And I did not realize that your lectures are posted on the CMAA class page, not on the billing class page. So
Oh,
I had
really?
So I was like, I haven't seen any of the lectures. I've kind of just been winging it. I've looked at, last semester stuff and looking at her PowerPoint presentations. And then I said, if there are links to Karen's classes, I kind of need it because I need the information about like missing class or bad weather. Kind of need that. And they're like, oh yeah, not a problem. So Amy sent me your last lectures from the time you taught before this. And then finally, I was like, I don't think those are right. The angle is just not right.
Yeah.
And then Jamie got on and she emailed them to me and she goes, yeah, if you need them, just let me know. We'll email them to you. I'm like, thank you.
So they must not see, because in the times before, it has been two completely different classes. So probably this time where we're doing half CMAA and half billing, I bet you they can't physically separate the lecture onto the two different things.
Exactly. So I was like, not a problem. I said, yeah, if you can send them to me just because, with the bad weather that's going to be coming in January, February, I need to make sure that I have access to your lectures in case we have class one way or another.
Yep. Yeah, that's true, because pretty soon, knock on wood, but I'm sure the snow weather is right around the corner.
Well, and so when I had texted you about class on Thanksgiving, Thanksgiving week, and you were like, oh yeah, I said it at the end of the lecture, and I'm like, what lecture?
I know, I didn't even, when I typed that, I was like, I didn't even think you wouldn't have access to it.
Well, I didn't think I wouldn't either, because normally, like, I had the CMAA, but then I had the coding, so each one was on its own thing, so I just assumed it would be on there. And it's weird because the older ones were on there. It just wasn't the newest one. So I didn't know if maybe they were just lagging and posting it, or maybe the technical difficulties were so bad that they were never
just
able to.
Because it was a completely different class.
No.
Yep. So
I'm all good now, though. All caught up.
All right. Good to roll. So tonight we'll do Chapter 8, which is the electronic claim. Again, as with weather, if weather is bad and schools are closed, you will get either an email from the school themselves, not this school, but the academy, or you will get a email or a call from me. If I send out an email, you'll see that I put in there, please let me know you got this. So that way, if, come 2 o'clock, I haven't gotten an email from you, then I'm going to try to call you, because obviously I don't want anybody, driving out if there's no class. So we'll always make sure someone gets in touch with you. And I did call Mount Ararat this morning. They will, hopefully, she said, by next week, they will know their schedule as far as Christmas goes. She said right now they were supposed to be off, whatever it is. It's like the week of the 21st. They were actually going to have like the tail end of that week and then the next week off. So they had like a week and a half. Right now, I guess they're trying to decide with the loss of power that they had with the storm, and the school was shut down for an entire week. They're trying to go before the board and see about getting that changed so that they would actually be here the week of the 21st, so we would have class, and then that next week of Christmas we would have off. So I will let you know as soon as I know whether it's going to be 1 or 2 weeks that we'll be down for the holiday there. But tonight we'll do the electronic claim, and a lot of this is, or not a lot of it, but some of it is the technical aspect of it, which you may or may not be the person that takes care of the techie stuff in your office. I'm not, and I get very frustrated when I call an insurance company, and I'll mention it in here in a few minutes, but when I call an insurance company and they'll say, well, what did you submit in this version on the claim form? Well, on the claim form, when I fill it out, it's it's box 12 or box 13, whatever. Well, when it gets sent electronically, it's encrypted until it gets to the other end where they pull it out and unencrypt it. But while it's encrypted, my box 12 might be their box 2488. So they'll be saying box or form 2488 or something like that, and I'll have no idea what they're talking about. So the technical side of it, and you'll see in here, they do give us several pages where they talk about what box on the claim form is, a certain thing, and then like box 9, other insured's name, but on the electronic format, it's loop 2330. So what I found I did is I just took these pages and I actually printed them, copied them out of my book, and just put them in a binder. So if I get on the phone with an insurance company and they start talking loops to me, I can look at this reference and know what box they're talking about on my claim form. So you'll see what I mean in a little bit. But the electronic data interchange, or EDI, is exchanging the data between computer systems. So like for example, exchanging information from us, the doctor's office, to the insurance carriers. So the information is sent back and forth in a standardized format via computer linkages, or what we call trading partners, meaning sender and receiver. So again, technology has made processing transactions more efficient and reduces administrative overhead in a lot of industries. For security purposes, they are encrypted, as I mentioned. So they cannot be opened and read if they are intercepted by the wrong individual. Encryption is a secret code to represent the data, so to keep unauthorized people out of it. It's encrypted so that the data looks like gibberish, and that's exactly what it looks like. I opened it once and I was like, that is not my claim form. But it's because it was encrypted because I wasn't using the right system to get into it. Both computers must speak the same language. So standardizing transaction and code sets are required for electronic data interchange effectively. So they have witnessed this with the implementation of standard formats, procedures, and data content through HIPAA. And this was a big part of HIPAA, was the electronic transmission, getting not only claims sent electronically, but getting money, electronic fund transfers, electronic EOBs, doing referrals electronically. So it was a lot more than just claims. But an electronic claim, like paper, begins with the information that we put on it for reimbursement. So it's the procedure codes, the diagnosis codes, the patient demographic information. If the submitting an electronic claim goes electronic, but if we're submitting via paper, we're going to use standard mail to get the claim submitted. We used to do everything was submitted via paper claims, and we would mail weekly hundreds of paper claims out the door, which is absolutely fine. Some offices still do paper claims. We'll talk about if they meet certain requirements. They're not mandated to submit electronically. If their practices are real small, they can still submit via paper. One of the problems with paper is snail mail, so it could take 30, 60 plus days to get reimbursed. Whereas if you're submitting electronic, everything is real time. So if we submit those claims electronically today, I'm going to have tomorrow morning when I go in, I'm going to have an acknowledgement of the receipt of those claims, and any claims that didn't make it through the scrub process so that were denied are going to be on that report. So I can fix them tomorrow and get them back out the door, and it's only one day later. Versus if you're waiting for the mail, you might not get it back for 3 weeks, then you've got to fix it and send it back. So that's one of the disadvantages for mail. They would have to have a waiver on file with their Medicare Administrative Contractor, or the MAC, as well as some third-party payers if they did not submit claims electronically. And again, there will be a spot here where we go over what those requirements were for not submitting electronically. So what are the advantages of electronic claims? Unlike paper, no signature or stamp, no search for a third-party payer address. We don't have to make sure we're sending it to correct P.O. box or something because it's done via electronic numbers. No postage fees, no trips to the post office, no storing those copies of claims in a file cabinet. By submitting electronically, that audit trail, those copies of the claims are all in your practice management system. So they're all there for you to see. Cash flow is improved, less time spent processing claims. The information goes from one computer to another, which reduces overhead by decreasing labor costs, human error. After electronic submission of claim, typically it's 2 to 4 weeks for payment. I've been paid in 7 days before. So by submitting clean claims and getting them out the door, depending on the payer, and depending if you're getting electronic funds, or a lot of companies now, God forbid, they're doing their payments via credit cards. So they'll...
I hate receiving those.
I know, it's a pain.
Paper with the credit card is a picture of a credit card, and you have to go into your system and you have to put it in like the company actually called you on the phone and gave you their credit card and take everything in. It's
weird. Yeah.
Yep, a lot of companies are doing that now. So, but you do get paid a lot faster. But again, with mail, 4 to 6 weeks on average, and by doing it electronically, everything that's in your system stamps everything, so you've got an audit trail. So if Anthem says they did not receive your claim timely, that's all stamped in your system as to when those claims were sent. So you have the availability to support when you need to go to Anthem and fight that appeal. You've got all that information in your system. You can show when the claim was sent, when it was accepted by Anthem or the clearinghouse. All that information is there electronically. Versus if you're sending it in the mail, you have no idea where it ends up. Another important advantage of electronic claims is online error edit process, which can be incorporated in the software or clearinghouse. And again, this is where it checks the claims for you for errors before they're sent out the door. So you have the availability to fix those problem claims and resubmit them before they even go out the door. And that can be as simple as the patient's insurance number being incorrect, an incorrect diagnosis code, anything like that. Both paper and electronic start with gathering data. We have learned the information we need to obtain is crucial when submitting a paper claim. Again, therefore, accurate information. So if we transpose the numbers for their policy number or their ID number, that's going to delay the claim. Sometimes, if we don't have the name exactly as the insurance card has it, that's enough to kick back a claim. You know, these people go by I don't want to say abbreviated names, but their name is John, but they go by Tony. So when they fill out all their paperwork, it's all Tony, 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 Tony. That's how you submit it. The insurance company doesn't know a Tony. They know a John. So just that much information. Clearinghouses are entities that receive electronic transmission from the providers. They translate it into a format, again, supported by HIPAA. So when the clearinghouse gets a batch of claims, what they do is they regroup them, so to speak, depending on what insurance companies they're going to. So if I send just one great big batch of claims to a clearinghouse, when it gets to the clearinghouse, they're going to separate and they'll put all my Anthem claims in one batch, all my Aetna claims in one batch, all my Cigna claims, and then they send them to the right places. That's what a clearinghouse does. If you look down below, you will see, starts in the physician's office, billing office, whatever. You input the data, then you edit and transmit it. It goes to a software vendor clearinghouse, which does the edits for you, or directly to a clearinghouse or the National Electronic Information. They do their edits, and then they're forwarded to the individual carriers where they are either paid or denied. Obviously, if they're denied, they're sent back to you to fix. And if they're paid, they're either paid electronically, which goes directly into your bank account, or they cut a check to which the check and the explanation of benefits would be sent to you. If you get electronic payments, a lot of times your explanation of benefits will also come electronically, which means you're getting that much quicker than you are waiting for your EOB to come in the mail as well. With clearinghouses, again, your claims are checked electronically or scrubbed for missing information. If it doesn't meet all the data, it's rejected. It will not go to the payer. When they are rejected during the editing process, they're sent back with a report that lists what was wrong with it. So they're not just going to send it back to you and you're just kind of scratching your head going, what do I do with it? They're going to tell you what it's missing, member ID number incorrect, member not eligible, diagnosis code not valid, whatever it happens to be. Batches of claims that pass edits then go to the individual payers. So your advantages of a clearinghouse, they translate to a HIPAA format for you. It reduces the time of claim preparation, because let me tell you, when I used to have to do 500 claims a week to paper and then take those paper claims and sort them by carrier, put them in an envelope, address the envelope, go to the post office and mail them, it was a big pain. Cost effective, fewer claim rejections, fewer delays in processing, quicker response time, more accurate coding with claim edits, and consistent reimbursement. Some of the people will not use clearinghouses, and what they use is direct lines to the carrier instead. So Medicare, you can actually go directly to Medicare via a specific system that they use. So they provide the software, you just log in with their protocol and everything, and then you submit everything electronically directly to them, but you've got to have this specific software. Some of the insurances allow you to do direct data entry, which means if you only have like 4 Anthem claims, you can go right on to Anthem's website and you can go and key those claims in one at a time directly, but it's all real time, so then they're right there on Anthem's website. Depending, again, time and how you want to be able to track, those data entry. The transaction and code set regulations for EDI, so under HIPAA, we had to adopt standards to support that electronic data interchange. So the objectives of this component was higher quality of care, reduce administrative costs by streamlining the process of financial transactions, and as a result, we got HIPAA transaction and code sets, TCS rule. And they hoped with this, by implementing it, it would save $30 billion over 10 years. So the goal was to achieve a single standard when submitting claims for payment. Healthcare providers had been doing business with insurance companies before that would, if you submitted a claim to Cigna, you had to have your Cigna provider ID number. When you submitted to Medicare, you had to have your Medicare provider ID number. With this being in place, we have one number that recognizes the providers with all insurance companies. So it's much easier. We don't have to remember whose number is what and what needs to go where. Code set is a set of codes with their descriptions used to encode data elements, such as terms, medical diagnostic codes, or procedure codes. And prior to HIPAA, there were more than 400 versions of these national standard formats. So 400 different ways to submit a claim for payment. It was way too hard to remember. So now it's standardized. There's one. And this went into effect, this regulation, October 16th of 2003. HIPAA standardization, similar to using an ATM. Magnetic strip identifies the transaction more quickly. So therefore, the healthcare providers' offices benefit from less paperwork and, again, standardizing those data results. We talked in Chapter 2 about HIPAA, governing how a covered entity handles the health information. So whether you send that health information electronically or not, it needs to be covered by HIPAA. So HIPAA covers this transaction entity. If the provider submits electronic to any payer, we are a covered entity. For larger providers, if the provider submits paper claims to Medicare and has more than 10 employees, the provider is required to convert to this electronic transaction no later than October 16th of 2003. So when I said some can still remain submitting to paper, they would have to be a small provider and they would have to have less than 10 employees. Otherwise, Medicare mandate that they have to submit electronically. So this is when some of your smaller practices, we had a couple in this area, pediatrician and I think it was an ear, nose, and throat doctor. Individual doctor, one nurse, one office staff. Medicare was mandating them to submit electronically because of whatever qualifications they had, but they couldn't do it. So they ended up closing their doors. So this is how it affected some providers. A provider is not considered a covered entity under HIPAA if the provider has fewer than 10 employees and submit claims only on paper to Medicare. In this instance, the provider may continue to submit on paper, not required to comply with HIPAA guidelines. If the provider submitted only paper claims until and after April 14th, 2003 and does not submit claims to Medicare, then they don't have to comply with standardized electronic submission either. So again, a couple instances. If you look on page 266, just a flow chart of whether or not they're subject to comply with that electronic transmission. Transaction code set standards, they have been adopted for healthcare transactions. These are specific electronic file formats where the medical data is compiled and used throughout the industry. All healthcare organizations using electronic transactions have to use and accept the code set required under HIPAA. These codes have already been in common use throughout the industry. what was a standard in the healthcare industry and recognized by most payers has now been mandated under HIPAA. So these code sets are used in conjunction with the electronic transactions. Medical code sets are data elements used uniformly to document why patients are being seen. So these are our diagnosis codes, what's being done to them, our CPT codes and our HCPCS codes. Each covered entity is responsible for implementing and updating codes in a timely manner and deleting old codes. So if you're complying with this transaction set, come January 1st, when the CPT codes change, what this is saying is that I will not submit an code that was used in 2017 that got deleted come January 1st, because I'm going to have my systems all updated and I'm going to have all the current codes ready to go. If I don't and I use an old code that's been deleted, then it is possible that if it doesn't get corrected promptly, we can fall under scrutiny and be in violation and get fined one of those penalties that I talked about in the other book. So because we want to make sure to stay updated, you either subscribe to coding software that can be updated annually, or data files that do that updating for you. Now, just because a code has been deleted does not mean we delete it out of our system. Because if we delete it out of our system, it actually will remove itself from any claim that you've submitted that had that code on it. I learned the hard way. We deleted a code by mistake, and then we went to print a copy of somebody's claim form, and there was nothing on that line item. The code was blank. So you deactivate the obsolete code, but you do not delete it. If you do not have the availability to use software to update it, then you want to make sure that if you're doing it manually, you purchase your books. If that's part of your job, you purchase your books early enough. So like December, Friday, I'll probably start reviewing the CPT book for any changes that will affect our practice, and make sure that they're updated in the system, because I have to manually do it by January 1st. So that when they come in ready to roll the first of the new year, all the new codes, they're going to know what they are and they're going to have access to use them. Data requirements. Your role as an insurance billing specialist will likely require you to understand what elements are required to construct HIPAA transaction. So what is needed for that CMS 1500 form to go electronically. And you will be trained on whatever practice management system they have. Most of the practice management systems out there, they're all user-friendly. It's pretty much just getting used to how they want you to put that information in. Our system is great because when we put in the demographics, once they're in that screen, they populate everywhere else that we need them, including on the claim form. So once you get to know the feel for the practice management system, you'll be good to go. But there's, again, all different varieties. In addition to the major code sets, so the ICD, CPT, and HCPCS, several supporting code sets are available for medical and non-medical data. Supporting code sets are made up of required and situational elements. These supporting code sets are embedded in the data elements. We do not need to know all the specific codes, but it is nice to know what they stand for, so that when we're reviewing reports from the clearinghouse or on the phone with them about a rejected claim, we can know what they're talking about. So required refers to data elements that must be used to be in compliance with HIPAA, and situational means that the item depends on the data content. If you look on page 268, determining the required and situational data, Elements not currently collected for CMS can be complex. You learn this process when you are performing claim processing duties. We will be directly involved in the claim processing procedures and need to know the most important items to look for related to required and situational. With also HIPAA, the physicians got what we call taxonomy codes. These are self-selected by the provider. It depends on their education and training. So for example, pediatricians' taxonomy code is one number. General practice has one number. Orthopedics. Sometimes these taxonomy codes are necessary because institutional providers may choose not to apply for a unique ID number, and they will have to use this taxonomy code instead. And this went into effect beginning January 2nd of 2007. CMS required the taxonomy codes for facilities when they were submitting claims. Patient account numbers need to be assigned to every claim. Relationship to patient, so spouse, child, mother, partner, whatever. Facility code value. This identifies the place of service. That is something that is required. It's not something that is situational. It has to be on there for the claim to get processed. So the electronic standard HIPAA format is what we call 837P. So when we're filling out the paper version of the claim form, it's the CMS 1500. Electronically, it's called the 837P. And again, due to HIPAA security and privacy, this helped to cut overhead costs by making it a standard transaction. Electronically, we can now obtain authorization to refer to a specialist. We can submit a claim electronically. We can request and respond to additional information needed to process a claim. For example, just the other day, I got something from an insurance company that said, if you get a request from us for additional information, you can now download it directly on our website instead of resubmitting the claim with the attached information. So that way, if I downloaded it today, they're looking at it today versus waiting and going through that process. Healthcare claims, healthcare payment and remits, coordination of benefits, meaning combining with other carriers. Claim status we can check online. We can check to see if patients are enrolled or not enrolled in health coverage. We can check to see if they're eligible. We can see their premium payments. We can see their benefits, referrals, first report of injury, health claim attachments, and other information that might be pertinent. Each of these standard transactions is identified by a 3-digit number preceded by ASCX12N. So again, I am not going to remember what number goes where, but if I have a standard table that I can look at, then I have a better idea. So if you look at the table on 269, so for example, if I wanted to check eligibility and verification, the format I would use would be ASC X12N 270/271. So when I go online to do that, that may be what they ask for. They're going to do it in that format. Yes?
I'm confused a little bit, Karen. This confused me when I was working on the workbook because one of the workbook assignments is assigning like which is used for which.
Yeah.
And I'm just not understanding the purpose of it, what we would need it for when we're billing. I'm not getting it. So if you're going online to like an insurance company's site and you're looking for, I don't know, eligibility verification, it's going to ask you for that code?
No, what it's doing is if you're going on their site to check for eligibility, when they're giving you that eligibility information, they're providing it in that format, in that number format. So when I went on to, what was I in today? I was in Sedgwick, which is a workers' comp thing. And when I was pulling up the electronic remits over in the far right column, it would ask me what format I wanted. Did I want the 837P format, which is the electronic format, or did I want the CMS 1500 format? So it's just the format that they are going to provide you that information. So when at first I would go online and I'd see that and I'm like, what is that? What type of information am I going to get? And mainly it's telling you that it is the code set that is linked to HIPAA that is the standardized transaction for electronic eligibility.
Okay.
So that's why it's nice just to know what it's for. So if I'm looking for eligibility and I see that 270/271 pop up, I know I'm doing eligibility. That's all. It's not anything you need to remember to put on claim forms.
Right. Okay.
Yep.
All right.
Yep.
Now I understand.
Yep. And you can create a crosswalk, which is what I talked about. Like I photocopied, not this, but I photocopied the next few pages to create that crosswalk for myself. Because again, if you look at the next couple of pages, on 270, for example, if you look down at in the left column where it says number 4, it says insured's name. Well, if I'm talking to an insurance company on the phone and they say, you mean loop 2330, or they'll say there was nothing in loop 2330. Well, how do I know what loop is? When I fill out the claim form, I've got numbers. So then I just go to this, I find that loop number, and then I know what was missing on my claim. So that's easier for me to know what that denial was for. You would hope, and sometimes you will get somebody on the other end that will say, that loop is the patient's ID number, or that loop is the diagnosis code. But not always do you get someone that's going to give you that. They're going to give you what loop is missing, and you got to figure out what loop it was. Because otherwise you're not going to know what's missing on your claim form. So I just photocopy this and use this for the few times that I have to deal with the insurance companies if I have issues with a claim that's been submitted electronically. But nothing you need to, by any means memorize or anything like that. But you'll see it goes, there's the NPI number, 17B. So it tells you that there's actually 5 different loop numbers on the claim form where you should be putting that NPI number. So if they're telling you that one of those loop numbers is blank, we need to know what it is so that we know that that's the NPI number that needs to be added to that claim, and then you can fix it and send it right back out the door. So it's just converting our numbers on our claim form into their difficult numbers, or their complexity, I guess, if you want to say. But again, that's mainly just for your reference, or like 24E, diagnosis. So if they say loop 2400 is missing, I know I can go to this and see that 2400 is something to do with the diagnosis, the charge, or the procedure code. And then I know what I need to fix. On 275, they are working on, when this all went into effect, this electronic transaction, it was called version 5010. So everybody had to be 5010 compliant. If you weren't 5010 compliant with your practice management system, you either had to shut down your practice or you had to get a practice management system that was 5010 compliant. We had an old, we had MediSense, which was an old, I want to say dot matrix because that's the printer. But anyways, it was really old. they could not update it to be 5010 compliant. So we lost everything out of that system because none of it could be transferred into the new practice management system that we had to get that was 5010 compliant. So everything that was in that old system, we could keep it up and look at the information and try to collect old accounts for 3 months that they would continue to support that old system. But then it shut down, and whatever we didn't have, we lost. So making sure that the practice management systems that you get are open to adaptability or change, because in the works right now is a version 6020. So we just did 5010. 6020 is currently under development. So in the next 2 to 3 years, we may have a new version that we need to make sure we're compliant with. So if our practice management system cannot be upgraded to that new format, guess what? Got to change practice management systems again. So if you are looking for practice management systems, you want to see what they have, for adaptability for changes. So claim attachments. Claim attachments are supporting documentations. Certificates of medical necessity, discharge summaries, op notes. HIPAA identified a health claim attachment as one of the transactions where the standards needed to be adopted. The compliance date for this was January 1st, 2016. So again, now we have the capability to send these attachments electronically and meet that requirement instead of sending them via paper. Standard unique identifiers on 276 are used to identify specific entities with the electronic claim processor. So, for example, EIN, Employer Identification Number. This is assigned by the IRS. It is what we call the tax ID number, and every practice has it. And it identifies that practice in transactions when you are submitting claims, but also when you are enrolling or disenrolling in health plans. Standard unique healthcare provider. Health insurance plans have assigned a unique identifier to each provider with whom they conduct business. So this is what I meant years ago when we would submit to Anthem. Anthem would want their unique ID number on there. Cigna would want their unique ID number on there. But now, under HIPAA, all providers had to obtain a national provider identifier, which is assigned to each provider, and it's good for all transactions to all health plans. It's 10 digits, and it was effective May 23rd of 2007. It's a lasting identifier. It does not change even if the provider relocates and moves. The national provider number stays the same. Standard unique health plan identifier. Currently, health plans are identified in electronic transactions. The ACA requires implementations of standard unique health plan identifiers. So in order for the health plan to process and pay electronic claims, they had to have these unique health plan identifiers. You can see that some were small health, with the exception of small health plans. They were required to get this number by November 5th of 2014, and smaller health plans had till a year later to get that number. And they have to use them in standardized transactions, or had to use them after November 7th. So if that health plan could not get their number, they could not submit electronically. So everything would have to be done via paper. So they had forms and processes that they had to go through, just like we had to get our numbers. But the adoption of this increases standardization again. and brings a higher level of automation to offices providing healthcare services. Standard unique patient identifier. Both HIPAA and the ACA supported creation of a unique patient identifier system. However, because of privacy and security, that has stalled. So right now, this is still in process. It's on hold. It may come back to the table to give each patient a unique identifier, but I'm not sure how that's going to go over. There was a lot of headbutting with that. Practice management system. So this is your accounts receivable. Your accounts receivable practice management system can offer scheduling. It can also be electronic health record, word processing, whatever it is. But the goal of your practice management system is to prepare, send, receive, and process HIPAA, standard electronic transactions, get your claims paid, be able to submit claims, post payments. That's what it's there for. If you are in the market for a new practice management system, make sure the vendor understands HIPAA, including privacy and security rules. We have a notice of privacy practices when HIPAA went into effect. I'm sure both of you recall the first time you went into your provider's office, there was probably a 6-page notice of privacy and policy thing that they would give you, and you signed saying you were made available. It was made available to you. It only has to be signed once unless they make changes to it. But what it did is it went over all these rules and regulations about HIPAA, that we were going to protect the health information, how they could gain access to it, the whole 9 yards. Setting security access to patient files in the software, we have to make sure these practice management systems can do that. Indicating date and receipt and signature, for example, of a nurse practitioner. Some of the electronic health records were for MDs only. They did not provide for supporting MD staff. So some of them needed that nurse practitioner capability. Date of patient's authorization, maintaining files of practices authorizations, tracking requests, tracking expiration dates. These are all things that we want to make sure a practice management system can do. When accessing the functionality in accounts receivable, we want to make sure we can set all providers up as individuals to bill using their correct NPI identifiers. We want to key in all patient demographics and insurance information, and we want to be able to send claims electronically by batch, either directly to the payer or via a clearinghouse. Some of the practice management systems will sell you what's called like add-ons. So for example, our old practice management system, we could submit claims electronically to 3 vendors. That was what was included in that practice management system. So what we had to do, obviously, you know there's thousands, hundreds of insurances out there. So we had to decide what 3 were our top 3 and how we were going to go about this. So what we decided is if we could only submit electronically to 3, Medicare was our big one, Anthem, and then we had to use the clearinghouse as our 3rd one, which meant that if it didn't go to Medicare or Blue Cross, everything else was going to that clearinghouse in order to go electronically. If we had to do anything other than that, so let's say the clearinghouse didn't take main care claims, then main care we had to drop to paper and send separately, or a small insurance company. So when you're looking at those practice management systems, do they limit you on how many vendors you can submit to electronically? Because if they do, and they say you can only submit 1, then you're going to have to use a clearinghouse. So you want to make sure you have that capability. Building the claim starts with the encounter, or what we call multi-purpose billing form. The encounter form can also be called the charge slip, multi-purpose billing form, routing form, super bill, whatever you refer to it as. It is standardized, or excuse me, customized for your practice. If you use paper format, it should be changed yearly when your codes change. So October when your diagnosis codes change, if any change pertinent to you, and January 1st if any procedure codes change. You can get these pre-printed, and what happens is after your provider sees the patient, they circle the CPT code, they circle the diagnosis codes, and they give that to you to submit for reimbursement. Some encounter forms are scanned to input charges into the patient's computerized account. This is more efficient. It avoids errors, and time is saved by doing that. But your system has to be able to accept that scanned format. So when it's scanned, it will pick up that CPT code that the provider identified and put that on the claim form. When one is operating computer software, it may be used to obtain pertinent information. So sometimes you're prompted on your screen where you need to key that information in. Each treating physician, referring physician, patient, third party would have an assigned computer code number. So again, this has more to do with the providers when they're filling out, for example, their electronic signature. They would be putting a special code, and that code knows that that's the electronic signature for that provider. Because there are computer code numbers and prompts for each item, this also eliminates a chance of error. Some entries can be made by using a macro. So menu selections, keystrokes, something like that, templates. But again, however, when using a macro or an automated billing system, we have to ensure that the provider accurately individualizes each record for that individual visit. Cutting and pasting is not allowed. And that's one of the first things that they look at to see if the provider is cutting and pasting his visits. Because if they just saw them 2 weeks ago and nothing's changed on the history, but they did a different exam, if he just takes that history from 2 weeks ago and cuts and pastes it into the new office visit, if somebody comes and audits that record and it's exact, that history is exactly the same, they're going to not count that because they're going to say it was cut and pasted. He didn't do another history. So then he could lose the cost of that visit. Some do's and don'ts for keying in data. Do use patient account numbers to differentiate between patients with similar names. That's pretty common anytime practice management systems, when you enter a patient in that system, it assigns the patient an account number. Do use correct numeric locations for service codes, CPT, HCPCS. Do print an insurance billing worksheet or perform a front-end edit to look for and correct all errors before they're transmitted. So in other words, it's telling you to scrub your claims. Do request payer reports so that you, again, can make corrections and get them submitted back. Obtain and cross-check electronic status reports. So in other words, if we sent 23 claims, we want to make sure they received 23, 23 were accepted. Do not bill codes using modifier 22 electronically unless you attach the documentation, because that modifier 22 says it was significantly separately identifiable. So how are they going to know what was significantly separately identifiable about it if you don't attach the notes? Once that information is all put in there, then we can submit the claim. If you look on 278, this is a pretty nice super bill, is what we call them. So if you look up on the top, it has patient ID number, what they have for insurance, which doctor they're seeing, social security number. It would give the last diagnosis code if the patient had been seen before, and then the appointment date and so forth if they have a balance, which some of this stuff you don't have to have on there. It's customized, so you can put on it what you want for your practice. You don't have to put all that information. But then you can see here that it's got the CPT codes and diagnosis codes. So you'll see to the left of it, it's got a 1, 2, 3, 4. What happens with that is it allows the provider to put which code they want first, second, third, or fourth. Now, just because they want it that order, it's our job to make sure it can go in that order. They don't know what can be billed with what. So that's where we come in. But it's there as a guide for them, because if we can get them to put that, then it's easier for us to go by this than to have to go back and ask them. So this is a good example. And then down at the bottom, when they were to come back or anything like that. Up on 279, this is an electronic practice management software. So you can see you would just key in your patient demographics. And then down to the bottom, which would be another screen, it allows you to put the insurance information. When we put the insurance information in on ours, actually this one has it also. This is over to the right. It says eligibility. So when you key that in, you hit the eligibility button, and as long as that insurance does electronic eligibility, it will come back and tell you, yes, that member is eligible today, this is their copay, this is their deductible, whatever it happens to be. So it's kind of nice to get that information. Because the healthcare provider is responsible for submitting accurate bill, the insurance billing specialist needs to input the codes. Medicare and other third-party payers are forbidden to recode a claim. So if there's something wrong with that claim, or that code is not does not meet their local coverage determination or whatever, they can't change it to the right code for you. It's going to reject, come back to you. You need to change it and resubmit it as a corrective claim. An encoder is add-on software. So this is something that's built into your practice management system, or you can purchase it separate if it doesn't come with it. And this is what scrubs your claims before they go out the door. So this will tell you if you're, for example, billing a hysterectomy and you use a diagnosis code of hysterectomy, and you use a diagnosis code of arm pain. This encoder will say that arm pain is not a diagnosis code that supports a hysterectomy. So there you can say, oops, because one thing to remember is your doctors, especially with electronic health record, if you saw them 2 weeks ago for, and we see it all the time in orthopedics, we see them for a shoulder issue. And now 2 weeks later, they're coming back because they fell and they twisted their ankle. If the doctor doesn't change the diagnosis to ankle for this particular visit, it's going to pre-populate with his last diagnosis code. So that can cause an issue when I go to submit the claim if the diagnosis doesn't support the procedure codes. So that Encoder Pro is something that will help do that. It also, the encoder can pick up if, for example, you're billing a code that is 1 lesion or 1 to 10 lesions, and you bill it as 2 units, it will tell you, are you sure you did 20 lesions? Or did you really mean 2 lesions, which if it says 1 to 10, you can only bill that code once. So it will pick up on little things like that too, which is really nice. Final considerations in building a claim are the signature requirements, both for provider and patient. So the physician's signature on the agreement or contract with the insurance carrier is his substitute for the signature on claim. So when he agrees to accept what Blue Cross is paying and he signed that contract, that's his signature on file. For the patient, the signature needs to be obtained and retained in the records, because obviously we are not going to have them sign each individual claim form. This can be on your patient registration form, and if you look up at the top of page 281, this is a patient's Medicare electronic signature monthly authorization or a one-time. We do not put specifically Medicare, we just put patient's electronic insurance signature, and ours is a one-time. Sometimes if they come back in 2 years and we have them update a demographic form, we will have them re-sign. But once they've signed this, it is fine for you to continue to use. So their signature on file would end up going in block 12 and block 13. If a physician sees a patient in the hospital and they've never been to the office, the authorizations that the hospital get from the patient will cover you in the office to submit those claims electronically. Clean claims. These are key to keeping your revenue cycle going and not getting delayed payments, which can take 30 to 100 days sometimes. If we submit a clean claim, the chances are increased that we are going to get paid promptly. According to experts, 90% of claim denials are preventable. How can we ensure that we get a clean claim? Have that encoder software or a scrubber. Verify, file, and keep all your transmission reports. You have proof that they've been submitted and received. Track clearinghouse claims to make sure they're successfully received. Ensure your software is consistent with the claim rules. Verify your software prints the claim form correctly. Use encoder software, use an electronic clearinghouse, and do either single or batch claim reviews. So you could either review each claim individually, or you could say, here's 20 claims, check them all. Putting HIPAA transactions to work. Interactive transactions are back to forth communications between the two computer systems. Real time allows for instant information. So you make an inquiry and you're going to get an answer. This can be with verification of eligibility, deductible status, claim inquiry, status of claims, other insurance information. Sometimes it can be your fee schedules, the allowables, anything like that. So by doing the interactive transactions, if I've submitted electronically today, and let's say tomorrow morning I get my batch that says all the claims were accepted for processing, let's say Monday I want to see if any of those claims have paid yet. Electronically, I can go in and see if any of them are waiting for checks to be cut or if they've already been sent electronically. You can check that information. Before, you just had to wait and see if you got the check in the mail or wait for that denial to come back. The electronic fund transfers, again, EFTs. This means that the money is sent directly into your bank account, which means you don't have to wait for a check. You don't have to do a paper deposit, and you don't have to go to the bank. When you do electronic fund transfers, you want to make sure that you set up your batches to, if that electronic check was for $1,000, you set up your batch for $1,000, you post your payments, and at the end from that electronic remit, you should have that $1,000 worth of payments, and now you should be at a zero balance. So you have to have that check and balance for those. Under the ACA, the federal government established a uniform procedure, again, for electronically transferring funds as part of HIPAA. So starting in January of 2014, some of the plans said you had to receive money electronically. They would not cut paper checks anymore. And some of them referred to paying by credit cards instead of cutting checks, because it's less cost to them. On page 282, we also have the ERA, or Electronic Remit Advice, which is the notice of payments and adjustments sent to providers, billers, and suppliers. It explains the reimbursement, the adjustments, what's being paid, what's the patient responsibility, and if it's denied, it will give us a code, and we can look down at the bottom of the ERA and see what that code means and know what we need to fix and submit. If you so elect, some of the medical practices can set their practice management software to, when they get an electronic remit, it will post it for them. If you do that, I highly recommend that the first few times it happens, you double check the posting, because there has been a few errors where they can't always interpret what that ERA says, or they may not do the denials correctly. But it can be set to automatically post for you, which if you're in a big practice and you see a lot of Medicare patients and you've got a $50,000 Medicare remit, if you hand posted that, that could take you all day. But if you set your system to post it for you, it will post it for you. You just want to review it to make sure that if you had denials or if there were balances going to secondary insurances, that you followed up on those to make sure that they truly drop to the secondary insurance. The Medicare ERA, Electronic Remit Advice, was formerly called Explanation of Medical Benefits, or EOMB. And sometimes you will still hear it referred to as an EOB if you are receiving paper format of that. Again, the version 5010 does electronic remits similar to the paper version. Basic procedures for transmission of an electronic claim. Again, set up the database, enter the data, batch those claims, connect the database with the clearinghouse or direct to the payer, send the claim, and review the report. So we key the data in, batch them, send them, check them, and then post them, review the reports. Methods for getting claims submitted to either payer or clearinghouse vary. Again, you can do it via data transmission, cable modem, digital subscriber line, or T1, which is a voice type thing. Data directly keyed into your payer system, or data direct entry, or PMS and in-house shared system. Again, it's going to depend on how you want to submit your claims. Typically, you're probably going to use number 1 or 2. You may use the direct data if you only have a couple claims to submit to a particular insurance. Probably going to use data transmission for the majority of them. Computer claim systems. Fiscal agents for Medicaid, Medicare, TRICARE, and a lot of the third-party payers use carrier direct systems, which means the data is transmitted electronically directly into the payer's system. That means there's no clearinghouse. You do have to have a signed agreement with each carrier, and once enrollment is complete, a submitter number is assigned. You have to submit a test file, and when you submit that test file, your test file is actual patients, actual claims. But a test file is not going to be actually processed. They will tell you, make sure that everything is on the claim that you need to, and that it looks good and it's okay to submit. And then once they say, yep, your test file's good, you're going to actually submit those claims. But a test file is actually not going to process. If you look on 283, this is a Medicare remit, or that ERA. So you see you've got your patient name, you've got the dates, we've got deductibles, all kinds of good stuff on here. The majority of explanation of benefits basically contain the same information. They'll have your patient information, patient ID number, date of service, what you charged, what they allowed, what they paid, and what, if any, patient responsibility there is. 284, again, here's the remit that says 1 would be, if it said patient responsibility and had a number 1, that would be the patient's deductible amount. 2 if it was co-insurance, and so forth. For example, M20, if the line had nothing paid and it had that code M20, that tells us that we have an invalid code. So we would have to go back, research, did we use an old and deleted code, or did we transpose the numbers, and then we could resubmit that. But those are the types of messages you'll get on the EOB, so you'll be able to see what's wrong with it and what you need to do. Your clearinghouses that you use, when you check for clearinghouses, you want to do your research, because some clearinghouses charge a flat rate per claim or a monthly fee. If they charge a flat rate per claim, depending on how many claims you submit, that could add up to quite a bit pretty quickly. If they charge you a flat monthly fee, let's say $30 a month, and you're submitting 500 claims a month, you're making out okay. But you don't want a clearinghouse that's going to charge you even $4 a claim, because if that claim you submitted, you only get reimbursed, let's say $20, now you've only made $16. So you've got to know about how many claims you're going to be submitting. And when you do sign with a clearinghouse, you typically have a business associate agreement that you sign and they sign, and it says for them that they are going to adhere to the HIPAA privacy, not breach the electronic transmission security or anything like that. When you submit claims, whether it's direct or through the clearinghouse, you will get a transmission report. You will have send and receive file reports, which will show that a file is received by the payer. You can have a batch claim report, which lists each patient's name, what was charged, billing number, name of insurance company. If you look on page 285, this is just to give you a rough idea. A is the transmission report. This is the one that if you look at it, it doesn't look readable because it's all that gibberish, because it's not in the right format. So once it gets formatted correctly, then you would be able to read and know how many claims were submitted and accepted and so forth. And then B is the readable version of it. So you can actually see what a difference it makes once it shows up in the readable format. On page 286, an example of the batch claim report. So it gives the individual patient name, the total charges, the batch number that it was in, their insurance company, when it was sent, total charges. And sometimes you're going to get the scrubber report. We submitted 6 claims, 8 charges, and total dollar amount. And this just says that indicates total number of claims, charges, and total dollar amount. They were scrubbed and they are then sent to the carrier. The scrubber report, that's what that was. Transaction transmission summary, how many claims originally received by the clearinghouse, how many claims rejected automatically. Rejection analysis, the most common reasons that claims are rejected. And then you make the corrections and resubmit. Electronic inquiry or claim status review. They list the files received from the office, indicates the progress of the claim. So if they're sent to the clearinghouse and the clearinghouse confirms that they received them, that's the information we would see. The electronic processing problems, usually a status report is received electronically, again from the payer once they get the claims, and it will have an acknowledgement report and indicate assigned and unassigned claims, crossed over and not crossed over. The crossed over and not crossed over would be if it is being paid by a primary insurance, such as Medicare, and then Medicare is forwarding that claim onto Anthem because they have a secondary insurance. If it doesn't say that it's being crossed over to anybody, and we show that the patient has a secondary insurance, that means that we're going to have to do that crossover ourselves. They can't do it electronically for whatever reason.
So that means that it'll go to Medicare, and then it would be bounced back to us. We can't submit to both the primary and the secondary at the same time, correct?
No.
It has to go to Medicare first. We have to wait for a response.
Yep.
And that response could be forwarding on to crossing over to secondary. Or if it doesn't say that, then at that point we know that we have to submit ourselves to the secondary.
Right. Yeah.
Okay.
The reason you can't submit to both primary and secondary at the same time is you have to wait and see what the primary is going to cover to know what the secondary is going to be responsible for. And typically Medicare is set up to crossover like AARP, Main Care, Anthem, some of the typical ones, but they may not be able to cross over, let's say, to Harvard Pilgrim or Cigna. So if they don't
Bankers, like Loyal,
Bankers Life,
Bankers Insurance is something that they wouldn't be able to cross over. So now, when it comes back from Medicare, when does the practice management program, do they automatically reformulate that claim, or are you essentially doing a brand new claim to that secondary with the leftover balance that it says patient responsibility?
Yep. What ends up happening is, so once Medicare processes it, if we get it back in our system, if we show that the patient has secondary insurance, once that Medicare payment is posted and Medicare says, let's say, $30 is patient responsibility because they don't have the patient having secondary insurance. When it gets to our system, when we post that Medicare payment and it shows $35 due, patient, if we show that the patient has secondary insurance, what my system is going to do is my system is going to create a claim to the secondary insurance with a copy of Medicare's EOB, and that's going to get sent to the clearinghouse as a new claim, but showing what the primary insurance paid and what is due by the secondary.
So it'll have the same CPT and diagnosis code.
Yep.
Everything's the same except the amount charged will be the remaining amount. And
Right.
then there'll be an attachment. Okay.
Yep.
I see.
Yep, so you really don't have to create a new claim. The claim's already there. It's just we're sending it to a different insurance now with that EOB.
Okay.
Yep. So again, the electronic processing problems will tell us what's crossed over, what's not crossed over, if claims have been rejected. The 5010 guidelines required providers to enter a physical address, not a post office box. So for a while, if you had a lock box where your checks went, which is just the bank, and they did the deposits, it wouldn't accept that post office box. You had to have a physical location. So you had to have your office location. So some of those claims would be rejected, and you would have to fix them. Zip code, you had to have 9 digits. You didn't have 9 digits in your location zip code, it would reject the claims. Anesthesia, if you were billing anesthesia and the minutes were reported as minutes instead of units, it was denied. Code qualifiers, guidelines said only an NPI. So we couldn't put the tax ID number where the NPI went. It wouldn't accept it. Just the NPI in the NPI fields. Again, the NPI be reported with all payers. And if we bill drugs, the 5010 guideline says that a drug quantity and unit of measure needs to be required. So if we're giving an injection of cortisone, we actually on the claim have to say how many units of cortisone we're giving and what the dosage is. Otherwise, it will kick back. Most billing softwares bundles claims into batches. If you bundle your claims into batches, some of the carriers, if the batch has an error, rather than reject just that one claim, they reject the whole batch. So that's something to be aware of. Again, if you look on 288, this is an example of a clearinghouse report. It's acknowledging a file. In this case, there's errors, and it's saying that the subscriber identifier is a mandatory element and it's missing, or there's an invalid character in the payer name, whatever it happens to be. It's clear as to what the problem is, and then again, all you need to do is fix it, and then you can rebatch it and send it out the door. Solutions to electronic processing problems: review the claims filed electronically by making sure that we have the correct information. So like the insurance information, patient date of birth, anything like that. Produce monthly aging of accounts. So this is something that typically is our job as a biller, that every probably 30 days you run a report to see how your accounts are aging. And if you have a lot of accounts over 90 days old, those we need to check into. Maybe they were submitted electronically and never received, and we never got a scrub report on it, or we never got a rejection report. So we need to follow up on those claims. File claims within the timely filing. Most of your carriers only allow 90 days to file a claim. So this is where it's important to make sure that we're doing that age report and checking how old those claims are, because we have to make sure we submit them timely. So if that place never got the claim and we're waiting 3 months to do our AR report, we're beyond 90 days right now, and if they say they never received it and we don't have a report saying it was accepted by that electronic carrier, we don't have ground to stand on for timely filing, which means that whatever that bill was, you just ate that cost. And I don't know about you, but you don't want to do that too often to the providers. Double check the correct code for the place of service. There's different codes that will be in your system. If it's done in an office setting, place of service is 11. If it's done outpatient at the hospital, it's 22. So you want to make sure that those are correct in your system, so that if you're billing an office visit, the place of service comes up as 11. Otherwise, if you're billing an office visit and it comes up as place of service hospital, those claims are going to be denied. Be accurate in linking correct diagnosis codes with the procedure codes. So again here, the hysterectomy with arm pain. That is not going to cut it. Maintain a schedule with EDI transmissions, which will help with better cash flow. So again here, depending on the size of your practice, you could submit every Monday to Medicare. Maybe Anthem is Wednesdays and your clearinghouse is Friday. But that stays the same every week so that you constantly have electronic claims going out the door. But again, it's going to depend on who your bigger payers are. To address rules of non-compliance with HIPAA, we have the electronic tool to assist providers. It's online, administration, simplification, enforcement tool. So you can go on, take a look at that, and see it enables individuals or organizations to file complaints against certain entities if you are, they're not processing correctly or providing certain information and so forth. Security rule, administration, physical, and technical safeguards. There are 3 sections for the security rule. The administration safeguards prevent unauthorized use or disclose of pertinent health information through development, implementation, and maintenance of security. The information access controls authorize each employee's physical access. So that's passwords, logins. It monitors who goes into what patient's chart. There's always a footprint. In the hospital, if you're logging into a patient's chart and it has nothing to do with your provider, but you're logging in because, let's say, that patient is your neighbor, there's a footprint of that. That means for immediate fire because you are violating that. It has internal audit reviews. So again, it's seeing who has access to that pertinent health information. Risk analysis and management is a process that assesses privacy and security and the safeguards. Termination procedures need to be formally documented in office policies and procedures and include terminating an employee's access to that pertinent health information. So once they're fired, you need to go in and disable their login and password. You don't just keep it up there. If an employee is fired, you deactivate them from your practice management system, from your electronic health record. That way they cannot access it because our practice management system is web-based. So if I got fired, if I still had my login and password, I could log in from home. So you want to make sure you get rid of all that. Technical safeguards, these protect and control access to information on computers. So this would be through limitations for each staff member. So if on Anthem, I only need my front office staff to be able to check eligibility, that's all I'm going to allow them to do. I'm not going to give them access to look at claims or payments. They don't need that. You limit it. Audit controls keep track of logins to the computer system and activity, and that includes changing passwords or deleting user accounts. And automatic log-offs prevent unauthorized users from accessing a computer when it's not being used. So after 2 minutes, if you're not there, your system would automatically log you off so that you have to re-log in before you go back in. And then your physical safeguards prevent unauthorized access to pertinent health information. Your media and equipment controls are documented in the policy and procedure regarding maintenance of the personal health information. So how do you handle retention, removal, disposal of paper records, as well as recycling computers when you get a new one? So what do you do with a tower? How do you wipe it clean? Physical access controls limit unauthorized access. So locks on doors, that's the most common one. Secure workstation locations minimize possibility of unauthorized viewing. So again, password protected screens or screens in the medical assistant billing area that the patients cannot see. So if I have a patient come in to talk to me about a bill, my computer is facing me, the patients are in front of me, so they cannot see anything on my screen. If I'm bringing up their account to talk to them about, I can turn my screen, but they are only able to see their information. So just taking precautions. All right, what we're going to do here is, I didn't think we'd make it all the way through, but we're pretty close. Oh, you know what? Let's finish it. We're close enough. Data storage. This just talks about making sure your system is backed up. Typically, your electronic health records, your computers, your practice management systems will back up, will allow you to back them up daily. Recommendation is they do it at night when the office is closed. So that way, if the system backs up tonight and tomorrow morning we can't get into the system, it's crashed, everything up through the end of today, we are still going to be able to rebuild. If you don't back it up nightly, then you're going to lose that time span. Like if you backed up last Friday and then you're not backing up again till this Friday and it crashes tomorrow, you've lost Monday, Tuesday, Wednesday, and Thursday. Everything that you've put in, charges, whatever. So we want to make sure that that stuff is backed up. Once a week, verification process should be done, comparing original records with copies. This can take 20 to 30% longer than an original backup. Store backup copies away from the office in case of fire, flood, or theft. Maintain a notebook of the documents on computer disks or CDs with an index. And that way you are able to track those files as to when they were backed up. And make sure somebody else besides, if you're the one that's doing it, make sure somebody else knows where that notebook is and that they're familiar how to track those records down if they need to. And then data disposal, again with HIPAA, the pertinent health information, personal health information, some acceptable methods of getting rid of the data, reformat, override the disk media several times so that it is sanitized, reinitial storage space of the hardware, break, incinerate, crush, destroy the storage device, shred audio tape, microfilm, microfiche, anything like that. Have surge protectors on your equipment for electronic power protection. And when you select an office computer system, if you look on 292, here are some things you want to take into consideration. Cost of the equipment, if it's purchased or leased. What about maintenance, hardware maintenance, and repair work? How much does that cost? What are the costs for the upgrades? How many people operating the system? Some systems only have 1 to 5 users. If you need more than 5 users, it's an extra fee. How much will consulting costs be? Backup support, response time. If there's a problem, they're not going to get back to you for a week to figure out why your system crashed. That's going to be an issue because if you're in office, you got to be able to go. How much time to convert current accounting system to the new one? You want to have a smooth crossover because you can't allow your AR to be affected when you are changing systems. Some mistakes made when selecting computer software. You get software that is not structured. Specific needs and requirements are not addressed. Consultant selected for advice is biased. Primary users are omitted from purchasing decision. If we're going to be the ones using the practice management system with the billing portion of it, we should be consulted to make sure it's going to do what we need it to do. And we have the correct number that we can submit electronic claims for. They don't know that. Practice buys more than required. Vendors allowed to dictate purchasing price. Senior management finalizes the choice of system rather than the people using it. And request for proposal concept is not used. So they don't, in other words, don't have the vendor come in and go over everything and look at more than one type. But the main thing is electronic transmission. It's standardized, it's easy to do, and now being that way, we're able to get those claims sent, get a response back within 24 hours as to whether they're accepted, denied, so that we can fix them and get them sent back in. Any questions?
I had a couple from
Okay.
before. Can you give me an example of a clearinghouse? Like the name, so that, because I'm trying to reconcile like the
MDON.
Okay.
MDON is a clearinghouse.
Okay.
I can't even remember the name of the clearinghouse we used to use, and I don't know. All of our claims go through Athena, and Athena actually hired a clearinghouse, and I can find out some other names, but MDON is the biggest one out there.
That name sounds familiar to me, but I was sitting there going, a clearinghouse, okay, and I'm thinking about how my system at work is set up, and I know that it's not going directly, like we're not directly going to Medicare. I know that there is something in between.
So they're probably
I'm sure it's probably a clearinghouse. Okay.
Yeah.
And a clearinghouse can do 3/4, I mean, pretty much almost all, with the exception of, because I know, for example, with the VA, we have, at our office, the VA claims are actually separated by VA electronic and VA paper.
Right.
Because it depends on where they're classified in the VA system. So sometimes we have to keep track. And right now we're having trouble because of everything with the funding.
Yeah.
So we had patients that their prior authorization cut off, so we had to get new visits. So they were originally a VA electronic, but now they're a VA paper with a totally different number. And we're trying to figure out, okay, did these old claims that were on the fence, did those go electronically, and are they going to be paid? Because they won't fall in the old PA, and it's just this weird mess.
Yeah. We're running into that too. But some of the clearinghouses, when you enter the payers in your practice management system, it will allow you to put the electronic payer numbers. So if there is no electronic payer number listed for that carrier, that tells the clearinghouse that those claims have to be dropped to paper. So they will in turn send those to paper and send any with the electronic EDI number electronically.
Okay. Yeah, because I've noticed because our office is small enough that when we have patients come in, they give us the insurance card, and I look on the back, I verify the payer ID. Okay, yeah, that's the right insurance. But then they turn around and like some of the payer IDs, when I look them up, they don't show up in our system at all. So I have to put them in as a manual, and the only way they'll go in as a manual is as paper.
Oh, wow.
So, yeah. So I don't know if that's just the way our system's set up, or that there may be an administrative function
That's
that
what I'm
can make
thinking.
that electronic.
Yeah.
But I don't know anything about that from my end, and I'm not quite in that position yet where I can say, hey, can I have access to be able to make this so that you can electronically submit?
Right.
Because usually it's just maybe one or two insurances. I mean, the bulk of what comes in is your standard, Harvard Pilgrim, they all come in, but some of them, there's like 7 different, Harvard Pilgrims. There's 12 different, anthems, and each one is a little bit different, but they're all submitted under the same thing.
Right.
But we still have all 12 of them in our system. We can't submit to Connecticut. We have to submit it to the local.
Right.
So it's a little confusing.
Yeah.
So I needed to understand exactly how that clearinghouse thing worked, because I was looking at the graph.
Yep.
And the way it was showing it, and I'm like, okay, that doesn't make sense. Is that like once it's edited and it's sent out, there were those 3 boxes. And I was confused because I'm like, well, okay, that means it's automatically sent, but I didn't understand where the clearinghouse fit in to those.
Yeah.
But now I understand that now.
Yeah.
The other question I had was when you were talking about the scrubbing of the claims.
Yeah.
And you were saying, the doctor needed to change a diagnosis. Like they came in, they originally came in for a shoulder, and they came in with an ankle. He didn't change the diagnosis.
Yeah.
you have a patient that's come in, they have a referral from their primary care
Yep.
for like, all right, let's say, the referral is for 12 visits for their ankle.
Mm-hmm.
So the doctor is, orthopedic, he's seeing him, okay, he's an established patient, the referral is for that, but then they come in between, and now they're having an issue with the shoulder. Do you need to make sure that that referral is changed? The diagnosis referrals changed?
It depends on the carrier. If it's one of the insurances that just require documentation from the primary care to the specialist that they were referred to us, period, then no. If it's a Aetna referral, where Aetna is actually issuing a referral number with 3 visits for the ankle, and now they're seeing us for the shoulder, yes, we need a new referral for the shoulder.
Okay.
But if it's a company that doesn't require a specific referral number, then no.
Okay, so if they're getting a prior authorization, because I know like Cigna does it for some of them, Aetna definitely does it, Anthem is big on it with their primary, that it's the referral prior authorization will come in, and it's been weird with Epic, the new Epic system, where each office is transmitting those differently.
Oh, wow.
To us, yeah, it's really weird. Like with Maine Health, because when they all converted over to Epic, so we'll have one office that sends it in a certain format, and then another office that's also in Maine Health has theirs set up that it's sent totally different. So you have to know how to read each one.
Wow.
And some of them put the prior auth number in a different place.
Yeah.
So when I was looking at it, it's like, okay, well, if they have, like, for example, because it's a podiatry practice, so you'll have Harvard Pilgrim, and they'll give you the authorization number, and the diagnosis is plantar wart.
Right.
So they start seeing us for the plantar wart, and it's for 3 visits. So when I see that, okay, they're on their second, the third one is scheduled, they're also being seen at the same time. It's like they're also having regular foot care things as well. So it's like a combination office visit, something else. So when I call, they usually ask me, well, what's the diagnosis? So I need to know what his new diagnosis is going to be, so that for that particular thing, so that it's correct.
Yep, because sometimes some of them will deny if you use the new diagnosis code and they've still got the planters on file, they're going to say that doesn't match the diagnosis assigned to that referral. Because Cigna does it with our surgeries. We'll pre-auth the surgeries, and we'll try to give them an idea of what we think the doctor is going to do. But if the doc gets in there and he ends up doing, lateral and medial meniscal, and all we did was off the medial, we need to call Cigna right away and have it changed, because otherwise I'm using the wrong diagnosis codes to support the auth and they won't pay it.
Okay. So as I'm looking at things with regard to referrals and insurance, it's important for me to be making sure that if it's a true prior authorization, where it's not just the MPI number of the doctor,
right?
That's usually, for the most part, what they do.
Yeah.
But if it's an actual authorization number, making sure that is the correct diagnosis code that he's putting on his encounter.
Yep.
Okay.
Now, one of the insurances does consult and treat, and I think on that one, when they use that, what is it, 94999 or whatever the heck it is?
I think so, yeah.
Yeah, that one is not specific to diagnosis code, so that one would not matter for that insurance. But if they are specifically listing a diagnosis for that auth number, then yes, you have to make sure you're covering whatever ones you're going to use.
Okay. Because I know a lot of what we get is normally just a general, ambulatory podiatry referral and whatever that code is. And I'm like,
Yeah.
oh, and that just covers just about anything. Or a lot of what we'll get is, what's the name? It's a diagnosis code. It's a diabetic with neuropathy.
Oh,
We'll get that a lot because those patients can be covered
Right.
by insurance. Like that's that weird gray area because not all like debridement of nails, all of that isn't covered by most insurances unless
Right.
they have neuropathy and all of those other things. So usually that's the code, and I have to make sure that that's the correct, because sometimes they accidentally put in the first level diabetic code, and I'm like,
Yeah.
no, it's got to say that it's neuropathy.
Yep, exactly.
Can you call and fix that, please?
Yeah.
So
I
yeah,
know.
it's very, very specific. Very
Yep.
specific.
Yep. You got that right.
Not always. That's the problem. 'Cause I'm
Yeah,
still learning.
exactly. But that's why we have our jobs, I guess.
That's the goal. That's the goal. This
Yep.
is my last. I did the coding. I've got my CMAA, and
Good.
I'm ready to have what the billing was the one I needed. I'm really upset that the academy decided that after I finished my CMAA
Oh.
and bundled, because they had bundled the coding together. So I took coding. Not that I regret it because it's incredibly helpful to me
Right.
doing it, but not too jazzed because as I got into my job, I realized, hey, I really need to know that billing stuff
The
a whole
billings.
heck of a lot more. Then I
And-
can pick up the coding. I can look up that book. That's easy.
Right.
But not knowing what the heck
Yeah.
I'm supposed to be doing with the billing, yeah, that's the problem.
Yeah. And it all depends what your role's going to be as to what part you're going to do. So.
Oh yeah, I'm actually very blessed because the office there's just two of us office people.
Oh,
And
nice.
then there's the billing person, so I actually have access to the entire process from check-in to check-out, and then in addition, doing, like if he's going to do a procedure, we call and do the prior auth. We're the ones that call and set up the surgery over at Southern Maine. We do all of that stuff too, so I have a very wide blanket. It's a great first job for me because
Oh, nice.
I can see this is what I like. This is what I don't.
Right.
I get a good basis so that I can go into, knowing once I finish this course, knowing what I want to do and being able to talk no matter what job I want to do, I can go in.
Right.
Like I can do a patient rep, which is not really what I want to do because that's very specific.
Right.
And I'm glad that I didn't do that. Like the small office really giving me, now I can say, oh, really want to do that billing. This is where I want to be. So
Right.
very cool.
Good. All right.
Thank you very much, Karen.
You're welcome. Have a wonderful week.
I will. You too. Have a good
All
night.
righty.